meeting of the Health Scrutiny Committee for Lincolnshire. My name is Councillor Richard Cleaver, and I'm the chairman of this committee. On my right is my vice chairman, Councillor Chris Reeve, and on my left is our Democratic Services Officer, Jess Wasser-Yates. Also present in the chamber is the Senior Scrutiny Officer, Tracy Johnson. Morning all. For those of us in the chamber, if we have a fire alarm or an emergency, we need to leave the council chamber through the rear doors, move through reception and assemble in the car park at the front and wait for further instructions. In addition to welcoming all members of the committee to this meeting, I would also like to welcome Councillor Steve Clegg, Executive Councillor for Adult Care and Health at LCC. Other participants will be introduced when we reach their item or when they first speak. The meeting is being streamed live via the County Council's website, and all your comments will remain accessible online after the meeting. With this in mind, I would like to welcome members of the public and of the press who are watching. Can I remind everyone to ensure their laptops and iPads are now on silent? So we'll move straight into the agenda. Item 1 is apologies for absence or replacement members. Jess, do we have any apologies to report, please?
Thank you, Chairman. We've received apologies from Councillor Paul Wimhurst, Suzanne Welbury and Lucille Higgs. Thank you.
Thank you. Those are noted. Item 2 is declarations of members' interests. Do any members wish to declare any interest?
On behalf of Health Watch, my interests are lodged with those, but just so I work for Lincolnshire District Medical Services, which run GP practice, so just in terms of item 2. Thank you.
Thank you for that. Anyone else? So I need to declare that I have been appointed by Lincolnshire County Council as their partner governor representative on the Council of Governors of North West Anglia NHS Foundation Trust. That's quite a mouthful, isn't it? If you become aware of any interest at any point during the meeting, you can declare it then. Any interest declared will be recorded in the minutes. Item 3 is minutes of our previous meeting on the 19th of November. We need to confirm the minutes of the meeting held on the 19th of November as a correct record. They're found on pages 3 to 10 of the agenda pack. Councillor Mackinson-Saunders. Present minutes. Can I have a seconder, please? Councillor Martin, thank you. All those in favour, please show. Any against? Any abstentions? Councillor Smith, thank you. So the minutes are approved. Item 4 is Chairman's announcements. So the next item on the agenda is my Chairman's announcements. The original announcements were circulated with the agenda as pages 11 to 13, and additional announcements were circulated to members by email yesterday morning. I should like to draw the committee's attention, particularly to the NHS's update on the current situation with winter flu, vaccinations and hospitalisations in the county, and also the latest government announcement on dentistry, which is relevant to the next item on the agenda. Does anyone have a question or comment on the announcements, please? Councillor Mackinson-Saunders.
Well, I have lots of comments to make about Grimsby Hospital in particular, because it's the one that serves the north of East Lindsey, where I live. But I'm glad to see that they're coming next month, and I will confine my comments to then. I'll just have to work out how I can talk about the really important issues, not just the issues that the Minister was looking at, but there are some. I've got some really bad misgivings about treatment at the moment.
Thank you. If you'd like to email your concerns to me, I can make sure that those who are going to come and speak to us are aware of them in advance of writing their report.
Yeah, I think that would be only fair. Thank you. MPs are involved now, so
thank you. And any other comments on the Chairman's announcements? Anyone? No? Okay. I take the announcements as noted. Thank you. Item 5 on the agenda, NHS Dental Services in Lincolnshire. Item 5 was circulated as part of the agenda pack on pages 15 to 57. This is the first time in the new County Council term that the committee is considering NHS Dental Services. As NHS Dental Services operated differently from the rest of the NHS, links to the background information have been emailed to the committee and are also repeated on the first page of the report. The presenters who are with us today are Sandra Williamson, Director for Health Inequalities Prevention and Regional Collaboration, NHS Lincolnshire Integrated Care Board. Vanessa Hales, Head of Primary Care Services, East Midlands Primary Care Team. Kenny Hume, Chair of the Lincolnshire Local Dental Committee. And Andy Fox, Consultant in Public Health at Lincolnshire County Council. Welcome to you all. Joining us online is Anna Ireland, Consultant in Dental Public Health at NHS England. Thank you for attending. Would you like to talk through your presentation in about 10 or so minutes? Thank you.
Good morning, I'm Vanessa Hales. Thank you for the opportunity that you've given us today to present to you. I just wanted to touch on the point that you'd made. There's been a lot in the media about dental and changes. Should anybody have any questions outside of this meeting, please feel free to contact me directly at any time with any questions. I will take the paper as read, though there are some points that I would like to highlight in the document. The first one is point 3, which is NHS dental access within Lincolnshire. Figure 1 shows the overall dental access rates for 2024 and 2025 for Lincolnshire. This indicates that in 2025, 25.84% of the total population are accessing NHS dental care, slightly lower than the national average. What is good news is that the figure 1 shows that the increase in access for the same period. So it is encouraging progress as a whole for the area. Furthermore, I just wanted to highlight that, again, figure 4 shows further improvements in dental access over the last couple of years. For children and young people, general dental contracts in Lincolnshire are commissioned to provide care for both children and adults. There is data within the paper which is encouraging. There is a slight increase within this segment of the population. Since we attended in February 2025, there have been no contract terminations received in Lincolnshire. Further good news. We do have a Lincolnshire dental strategy, and the aim is to provide a roadmap for the ICB and its partners for action that's needed over the next 2 to 3 years. The strategy's 4 pillars: developing the dental workforce, improving access, increasing the focus on prevention, and strengthening the integration of oral health into wider healthcare services. Communication plans being developed to support this strategy, and this will support implementation by engaging stakeholders, raising awareness, and increasing public understanding of the changes and behaviour around oral health. It's a really exciting time for Lincolnshire at the moment, with the establishment of 2 new institutes based at the university. The first one is the Lincolnshire Institute of Dental and Oral Health, known as LIDO, and the second is the Lincolnshire Institute of Rural and Coastal Health. LIDO will focus initially on training dental therapists, but in time it is hoped that training for the whole dental team will be part of the programme. You may be aware of the government's manifesto, which was to commission a target for the whole of the country of 700,000 urgent dental appointments. The team have worked really hard to commission those. Within Lincolnshire, the required numbers was just over 12,000. They have been commissioned and are available. So that shows an additional 34% of additional appointments that have been available. What is challenging is the take-up rate is below the trajectory. The appointments are available, but they aren't being accessed. We have been working on a communication plan to raise further awareness with patients and the public, and also ICBs in the East Midlands have come together to work on a communication strategy that includes Google search advertising, Facebook, Instagram advertising, some radio advertising and some flyers. Tonight we are holding a drop-in session where we invite all of the providers of this work to come and talk to us, to tell us what they think is working well, what needs to be improved. We got some excellent feedback last time, so I'm looking forward to what they tell us tonight, and you know, any more ideas that they can provide us to increase that access. So just wanted to touch on the non-recurrent scheme, which is per financial year, the orthodontic waiting list initiative. We've recently commissioned 265 additional case starts to ease the waiting list. We recognise that is a short-term measure to reduce the current risks for patients, but it does give us a little bit of breathing space whilst we work out a longer-term, more sustainable provision of services across Lincolnshire. For a recurrent scheme, we've been working on a project which provides UDA, which is units of dental activity, which is the method by which providers are paid. It's a really exciting project to have been involved with. Started 1st of November, and it's been looking at the payment rates for providers across Lincolnshire. The objectives of the scheme have been to address inequalities. We recognise that Lincolnshire was some of the lower paid rates, so we've moved those to bring them more in line. Rewarding commitment to the NHS, maintaining or increasing access, supporting recruitment and retention, and supporting complex or specific patient cohorts if required. And the way that we approached this scheme was we actually contacted every single provider within Lincolnshire, ones who were going to take part and ones who won't, just to take the opportunity to say, how are things working with you? Is there anything that we need to do? And it's just part of building those relationships. And it's been, as I say, a very exciting project, great to have been part of. Went live from the 1st of November. Pardon me. It's been a hypertension case finding pilot, which is sort of in old money. It's the making every contact count and looking for opportunities to test blood pressure in places that might not usually occur, such as the dentist and the optician. And so this has been running throughout Lincolnshire as a pilot to try and identify patients with high blood pressure. It's now complete and it's moving to a national evaluation. Sandra, is there anything further that you would like to add? Thank you very much. Does anybody have any questions for us?
Thank you. We now move to questions then. Yes, please indicate to me or the Vice Chairman if you wish to speak. Councillor Lee, you're already ready to speak. Thank you.
Thanks, Chair. I think we all know how hard it is to get a dentist. Earlier this year, I'm lucky I've got a little bit of life savings and I can afford to do it. I paid £43 for a checkup and then £250 for a filling plus a clean. So that's a lot of money. And with people here from the Health and Equalities Prevention team, so not everyone could afford to do that. I was lucky. I could do that. I don't think people always realise the link between poor dental health and cardiac health. Again, I was a cardiac nurse, so I do know coronary artery disease, and it's part of the wider public health strategy, preventing coronary artery disease and poor cardiac health. I just wondered if, very briefly, I don't intend to monopolise this meeting, but can you tell us a little bit about the link between cardiac health and poor dental health? Because I think this is going to impact on people who are poor and can't get a dentist, but also people in rural areas where there are no dentists. So it's just something around that, please. Thank you.
Thank you, Karen. Is my mic on? Yeah.
Yes.
Yeah. Thank you. I'll take this question if that's okay. Not only is the link between poor oral health and cardiac disease there, it's other things as well. It's diabetes. It's rheumatoid arthritis. They're making links between poor oral health and dementia. People in COVID times, those with poorer oral health had poorer outcomes. So it's huge. And I think the public sort of tend to pigeonhole dentists, well, we do teeth, but we do a lot more. And as Vanessa's alluded to, the blood pressure checks, involving the whole dental team has been really important, and the feedback we've got from patients has been fantastic on that. And not only are dental practices doing blood pressure checks, they're also doing diabetes checks as well, really. So there is a lot, dentistry is not in a little silo anymore. It's out there in amongst the profession, in amongst the public. And professionally, you may, at your next meeting, talk about the 4 pillars of primary care. Those 4 pillars, medicine, optom, dentistry, and pharmacy, really work very closely and very collaboratively in Lincolnshire. And also just on that subject of collaborative working, I'd just like to thank my colleagues here, Vanessa from commissioning, Sandra from the ICB, Anna's online and public health, how we in Lincolnshire really work very closely together. I know other areas where that synergy just isn't there, and we have that in Lincolnshire. So we are well aware of the link between poor oral health and general health. Thank you.
Thank you for that. Next, Councillor Smith, if you'd like to speak, please.
Thank you, Chairman. The continued development of the Lincolnshire Institute of Dental and Oral Health to increase the development in the workforce is an excellent thing for Lincolnshire. But obviously, it's a hard course. They train for a long time, so most of them, well, majority of them, will go straight into private practice because that's where they're going to earn a decent amount of money after they've done all this training, and they've got, obviously, debts from that training. It just seems a shame that we can't set up a scheme or a system where we could encourage them to work for the NHS for a year in the dental system, because then the service wouldn't be short of staff. And if they were paid equivalent, it would ensure then that we're not always short of NHS dentists. Thank you.
Again, may I take this as well from a clinical perspective? So you're aware of the announcement yesterday, you alluded to it, about the changes in the NHS dental contract. As part of those changes, there is consideration being given to tie-ins from the dental students. Now, you have to appreciate that it would be the only one of the only courses that there is tie-ins. There's no tie-ins in accountancy. There's no tie-ins in anything else, really. So it would be the only tie-in. But from a public perception, we understand this, that taxpayers' money are going to train dentists to work in train dentists, and then they end up qualifying and work privately. But you've then got to question why they do that. And why they do that is because the current NHS contract is not fit for purpose and has not been fit for purpose for 20 years. So we're in this situation for a reason, and if the NHS contract favoured people to work there, then we wouldn't have this problem, really.
Thank you. Councillor Kendrick, please.
Thank you, Chairman. I read in one of the reports a reference, and I think Mr. Humes mentioned it this morning, about hypertension, and there's a study that's been undertaken, and there's evaluation underway at the moment about that. I was just wondering when we might hear the results of that, because it sounded very interesting that, as you were saying, Mr. Hume, that dentists do more than just fix teeth, and I think that was very interesting. And my other point, if I may, Mr. Chairman, is I also noticed that NICE doesn't support routine 6 monthly checks, which is news to me. And I was just wondering, I don't suppose you would have any data on this, how many practices actually follow that recommendation, or do most practices still do the 6 monthly check? But that was certainly news to me, that it was a NICE recommendation. Thank you, Chairman.
Yeah, Sorry, I don't mean to monopolising this
fine.
conversation, but the questions are coming at a clinical perspective, so I'll try my best to answer. So the 6 monthly checkup was always like the standard, if you know what I mean. And really what we have now is a situation where there are some patients who are at risk who can be seen 3 monthly if they've got periodontal disease, and it's back to the link between periodontal disease and general health. And there's some patients who need to be seen far less regularly. You know, they've gone through, they've had orthodontic treatment, they're in their early 20s, they've never had a filling. So 6 monthly is perhaps not advisable for them. You heard, I think the Minister talked yesterday about 2 years. 2 years for certain people is acceptable, but if 2 years for someone who might be a smoker, someone who might have periodontal disease, that is a risk factor that just isn't applicable really. And but we're trying to move away from the standard. Every single person has to have a 6 monthly checkup. We are moving away from that, Councillor. Yeah. And your second point was hypertension. Yeah. I don't know when the national results are coming out. The results we had locally were really worthwhile, really, to look at, and we picked up people with very high blood pressure just randomly. In fact, we picked up one dentist who had very high blood pressure, and then we picked up another person of the dental team's partner. And it was one went to A&E and the other one went straight away to his GP, and these were significantly high figures. And the advantage of that is obviously, you know, we've hopefully prevented stroke, hopefully we've prevented a cardiac event. So the impact on that on the patients themselves and on their family is significant. But also from an NHS cost point of view, by doing these blood pressure checks, we have hopefully saved the NHS a lot of money because the individual didn't need subsequent care or stents or whatever it is really. So it's a health benefit, but also a financial benefit as well.
Thank you.
Thank you.
Could you switch your mic off when you're not speaking? Thank you. Councillor Martin, please.
Thank you, Chair. Thank you for that. It's very interesting report. Appendix A shows that there's no urgent out-of-hours care or extended access dental care in Grantham. I was just wondering if that's being addressed at all, or if you're sort of happy with, I think it's Sleaford, it says on the list, as being the nearest provider for that. But my main question also is revolves around patient anxiety. I understand 50%, according to stats anyway, I found 50% of the population is anxious about dentistry, of which 10% is so anxious that they'll probably skip appointments or not actually go. I was just wondering what kind of things you have to cover that, to try and encourage patients to actually, you know, go to their appointments and to be used within the county. I notice also we've got this thing called the Special Care Dental Service, which seems to say it will cope with extreme anxiety within patients. Is that something that is a known fact? Because I'd never actually heard of it before until I saw this report.
Can I bring Anna Ireland? Anna is online. Anna is dental public health, and I'm sure she would answer that question because you don't want to hear me droning on yet again.
Yep, happy to. Can you all hear me okay?
Yes, thank you.
Lovely. So, you know, not surprisingly, many people are anxious about going to the dentist. It's not a comfortable position for many people, even just sort of lying on your back and having someone, you know, footling around in your mouth is not hugely comfortable for many people. But there's a big difference between being sort of anxious and being so anxious that you can't have care. And there are different things that can be done, from just having a really good dentist who understands the problem and can talk you through it and treat you with respect and care and kindness, to the extreme end, which is actually you might need a general anaesthetic to have your treatment. That is very extreme, but it can happen. I spent many years working in a community dental service and having to examine people who were so anxious that we actually went out and saw them in their cars. They couldn't get into the dental surgery. There are things that can be done, so things like offering sedation with nitrous oxide, which is the gas that you have perhaps when you're in labour. And there's also an option for intravenous sedation, which is where you have drugs injected in you to relax you, basically, the same as you might have for an endoscopy. So the services that are offered for people who are anxious range from your regular dentist, who, as I say, can just be, you know, a kind dentist who understands you and can talk you through the problem, to someone like the community dental service, who have people who are expert in dealing with people with severe anxiety, and that's where you might be offered things like sedation, either through inhalation, through gas, or through drugs, or in the incredibly extreme example, through general anaesthetic. And the reason you probably haven't heard about the community dental service before is that it operates on referral. So patients have to be referred to the service. You can't just pitch up and say you want to be seen by them. And they will assess you and check that you're, you know, you fit their criteria and that you are the sort of person who is best treated by them. And unless you're in that situation or you have someone close to you who is, you probably won't have heard about them because they are a niche specialist service.
Thank you. Liz Ball.
So, excuse me, please.
Sorry.
Would it be okay if I took back your question about the urgent care in Grantham?
Yes,
I'd
please
like
do.
to look into that in more detail and then send a thorough response to you. Thank you.
Thank you for that. Sorry. Liz, are you going to the queue?
Just to say that special service for people who are really nervous, I was on that and I've been waiting 2 years and I keep just being told you never get to the top, basically, of the list. So.
Thank you. Liz Ball, thank you.
Thank you, Chairman. Thank you for your presentation. As Health Watch, you know, we've been quite close regarding dental health in Lincolnshire. And I know Dr. Hume and I were having a brief chat before we came into Council Chamber today. But it'd be really interesting to know when you provide that there'll be any changes as a result of the new contract which will benefit the residents of Lincolnshire. And then just a second, more a point than a question really, with the increase of dental therapists, I just wondered if you're considering how that will be communicated to the residents of Lincolnshire. I'm just thinking back to how general practice introduced a wider multidisciplinary team that sees patients, and some patients just have this perception that they just want to see the doctor when there are other skilled people within the multidisciplinary team, and how you might be starting to communicate that to the people of Lincolnshire, that it might not necessarily be the dentist, it'll be a team that will see them in the future. Thank you.
Thank you, Liz. I'll take this. So the aim of the changes in the dental contract, our ultimate aim is to change the contract completely. So contract reform, and the Minister has promised that by the end of this government's term, there will be contract reform, the whole contract. So these changes are interim changes, shall we say, and the aim is to firstly improve urgent care, and for urgent care to be a core part of the contract, so as we don't have stories of such and such having to get pliers in the mouth and so on. And the other thing is to improve access for complex care, because that really is an issue with this contract, really. Whereas someone who needs one filling and someone who needs 10 fillings, the dentist gets the same, the patient is charged the same. So we want to modify that, really. As regards information to public about changes. We're well onto that, really. We're working closely with the ICB and their teams. We recognise it is you expect to see the dentist, and it's different from medicine. You see the dentist, you come and see me, or you come and see one of my colleagues, whereas general practice is different, isn't it, really? So we are looking at skill mix as the way forward, but we as a profession have got to get skill mix sort of sorted out as well, really, so everything is joined up. But yes, we're aware of that, and we'll be trying our best to communicate to the public, you know, what the difference is between having a treatment done by a therapist or a dentist. But it is the way ahead.
Thank you. Thank you. Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. You scared me half to death today with some other things I can get, like strokes and things, because my teeth, I need to see a dentist. I represent one of the district councils, and I write all this up for my councillors, and I'm put to the test like you are when I get back, and they ask me lots of questions. So I'm going to ask you, what is the state of the dental service in Eastern Lincolnshire?
I think it's fair to say that rural and coastal areas struggle. There is a tendency for dentists, when they qualify, to stay around their area, and this is why we recognise this. This is why we're putting work in with the Lincolnshire Institute of Dental and Oral Health. That could be a real game changer. But also Lincolnshire Institute of Rural and Coastal Health. The two are working very closely together, really. Andy here has done the paper on coastal. Yeah, would you like to comment, Andy?
Thanks, Kenny. Yeah, well, just to say that across all of the disciplines, really, we do see significant inequalities in coastal and rural health. And we tend to find there's something called, in public health theory, we call the inverse care law, which basically just means that you tend to find that the need for population, or rather the provision for any kind of healthcare, definitely including dental, tends to vary inversely with the need for it. So in areas where you have a higher level of need, you tend to find less provision. That is a universal principle. Unfortunately, it's not unique to Lincolnshire. But some of the issues that Lincolnshire has structurally, with its beautiful big skies and coastal areas, it's just it is harder to get professionals from who have been medically trained to move out to these areas with young families often, because that's the stage of life they are, where the appeal of the cities does make an effect, and it doesn't need to be a huge effect to start to see some of those disparities in access starting to generate. On top of that, you have different health-seeking behaviours in the population and different levels of risk in the population. So we do have higher levels of poor dental health, higher levels of poor health in general in coastal and rural areas, and what we can see is sort of a less of a inclination to take up preventative offers of healthcare regularly, and a more of an inclination this is averages across the population, we can all think of counterexamples, but more of an inclination to wait till something presents as an emergency. And I think that is some of the many reasons why we are in the situation which you've described, and I do recognise, and Kenny has described as, we do see worse access and worse health in rural and coastal areas. That is a national issue. Lincolnshire has its own sort of reasons why we see that here.
I would also say, sorry, Councillor, just if I can add to that, I would also say, as we know, we're working in Lincolnshire here. Lincolnshire is a good place to work. So we are trying, collectively, we are trying to change the narrative, and you've heard the term dental desert. We are trying to change the narrative from dental desert to hidden gem. And, this is how our approach is being a positive approach as opposed to a negative approach. As I mentioned, Lido and Lurch are integral into that, working with their team, increasing the UDA rate, golden hellos, things like that, to try and encourage people to come to Lincolnshire, really. Because when they're here, they think, this is a good place to work. It's just getting them over that, come and stay with us, really.
Well, we're here to help where we can, so thank you.
Sorry, put my mic on. So just following on from what Councillor Mackinson-Saunders said there, do we have, I mean, the figures, particularly for East Lindsey, on the tables on oral health within the appendices are very striking indeed. So it begs the question if there is any way that we can locally incentivise. I mean, there was a programme, wasn't there? Is that going to continue? Is it going to be enhanced? Are there any other ways of incentivising dentists to come and work in those areas? And also, clearly, there's a problem of people actually wanting to have access and getting access. So I suppose the two things have to be taken in tandem. So I'd like to hear your comments on that going forward. And the other thing that's noticeable from the stats that you've put, I attend quite a lot of scrutiny committees, and one of the things I'm used to seeing is performance against a target. And on those MSOA graph tables, there's no target. Is that a national thing? Should we have targets in Lincolnshire and measure ourselves against those going forward? So, sorry, I've bundled a few questions together there. I hope you don't mind.
So there's a number of responses there. Could we just break it down? And one of the points that I wanted to raise, and if Andy could pick this up, please, was the supervised toothbrushing programme.
Certainly. So there is an element of prevention that we're trying to roll out across the county, and this is very relevant to areas that have high levels of disease and poor levels of access. So for many years, Lincolnshire was offering a supervised toothbrushing programme for early years childhood settings. So this is literally trying to teach those good life skills from an early age, where we do know there's many areas of the community where kids from a young stage, they just won't have access, they won't even have a toothbrush, they won't have access to toothbrushes or to toothpaste. And for whatever reason, they then come into contact with early years settings. There's an opportunity there for the nursery nurses, etc., to just teach them how to do it. And they literally supervise it. They brush them. That's something we've run through the Community Dental Services team in Lincolnshire for many years. And the government have recently introduced additional funding, relatively low level, but still significant, for across the country. I think it's 11 million across the entire country. So Lincolnshire saw about 86,000 or so, to introduce that into some schools programs as well. And again, there are some donations from the private sector, which is always welcome, from Colgate Palmolive in terms of some of the toothbrushing kits, essentially. And that work is now rolling out. That is county-wide, and we are, through, we're transferring commissioning of this service to NHS partners, but the idea is to incentivise targeting areas of highest need as part of that programme. And again, it won't, I would say it's a necessary corrective and a necessary part of the picture. Obviously, all of these things are complex, and so supervised toothbrushing will help, but it won't solve the whole problem, of course. Thank you.
Thank you. Could I just pick up on the target aspect? The main target that we have as a team to work towards is the commissioning of the urgent dental. We have a target they have to meet, and our progress is monitored. And it's very, very opportune that you've asked this question, because it's something as a team that we have been doing quite a lot of work on. And it's still in the very early days of development. We've had a couple of workshops within the team. I think we've got another meeting before Christmas. And it's looking at targets of how we're going to measure our performance for the next financial year. Still in very draft, so we're looking at where are we now? What's really going to be, what target do we think that we can achieve? Do we have one version of the truth, for want of a better expression? How are we going to consistently measure the same thing? And we're going to be pulling that together to set us off for the next financial year. So definitely, we're heading in that direction, yeah. And thank you for asking the question, enabling me to talk about that piece of work.
Thank you. And on the question of incentivising dentists beyond what we already have, is there any new scheme in the offing to incentivise dentists to set up and offer NHS services?
Yes, so just to come in on that, the current scheme that we've got on the incentive for attracting dentists and the workforce or retaining the dentists, some of you will have heard before is about the Golden Hello that we had as a local scheme in Lincolnshire. There was also a national scheme that was launched at the beginning of this year. So we've added both those together. We've been really pleased to have 11 applicants, so we're just going through that recruitment process as we speak. There will be a plan to continue with the incentive scheme as we start to develop the workforce model and the skill mix of the whole dental team. We'll be looking at what else can we be doing on the attraction for the workforce. And if I can, Chair, also talk about the point of what you've heard today is around our dental strategies, all around what the access, what the workforce picture, the prevention picture, and how all them come together. You know, Kenny's articulated really well that we've been waiting for the national dental reform, but we haven't stood still in Lincolnshire. And one of the big factors of the bit of work we've made progress this year is nationally there was an increase in the UDA rate, which is around £29. Our dental practices were still saying that was insufficient for Lincolnshire to do the very things that you're talking about, attract workforce to work in the rural areas, our coastal areas, our Pacific areas of deprivation. So we've honoured a commitment to start to look at that locally that tied in with the work we do on our workforce planning and training development, our prevention agenda, which is why you're seeing some good results now on our children access. And this last piece is all around improving that overall dental provision. So that £33 hopefully will go a long way in improving the access, which with what Vanessa's talking about, we've set an ambition of how to improve both adult access overall for Lincolnshire and in specific areas, and we're looking at the MSOA areas just alongside the children. So we should see that as our improvement for next year. Thank you.
Sorry, I'd also like to go on a little bit from that as well. We have talked about Lincolnshire Institute of Dental and Oral Health and Lurch. Those two institutes are attracting dental professionals as well, and we hope part of certainly LIDA will be training. So we need people to train dentists because the ambition of the university is to have a dental school, as you know, and in fact the advert has just gone out this week for a vice dean for the dental school. So that's really positive, and we hope that these institutes will then attract professionals who will then attract, and it becomes an ongoing situation.
Thank you. I understand Anna Ireland wants to come in online.
Yeah.
Thank you. I was just going to say a little bit more about targets. So as Vanessa said, the target that we're measured on nationally is our contribution to delivering the 700,000 urgent care appointments. But apart from that, we're not set local targets for things like proportion of the population accessing care. And that's what Vanessa was describing we're beginning to look at, is should actually we be doing that, and should we have different targets for different areas? So for areas where we know there's more need, should we have a higher target, for example? And we're working with stakeholders to think about these, I suppose, principles and targets, so that when we set them, they're sensible, achievable, stakeholders have bought into them. But in answer to your general question, no, there are no national targets on what proportion of the population should be accessing care.
Thank you. Councillor Mackinson-Saunders.
Yeah, I come from the generation where there were school dentists, and all children saw the school dentist, whether you had an ordinary dentist or not. If it's so important to get children cleaning their teeth and doing anything, why did that system disappear completely? I can't remember when it disappeared, because I can't remember my children going through it. But if that's the answer, why don't we bring back a dental service for kids in the same way as it used to be? You probably can't answer that because you're probably not as old as me.
Thank you for that. I think Anna wants to come in again. Is that right? Yeah, please.
Yeah, I can answer it, probably because I am as old as you, I'm sure. So the school dentist as it was something which stopped probably routinely. It must be about 25 years ago now, so quite a long time ago. And what the school dentists used to do is they'd go in, look at all the children in the school, and then let the parents know if they had a problem and say, you know, we think your child needs further work, go and find a dentist. And the reason it was stopped was that what was found is that parents saw this service as a substitute for going to the dentist. And it actually discouraged people from taking their children to dentists, which sounds counterintuitive, but they thought because the child was having a quick check by a dentist in the school, they didn't need to take them for care. And there was a piece of work done by the National Screening Committee, and this is the committee that looks at things like breast screening and cervical cancer screening and so on and so forth. And they concluded that it should not be continued, that this quick check, this screening check in schools should not be continued. And they have since reported and re-looked at the evidence, and their advice still stands. So that's why we don't routinely go in. What we do instead is, as Andy was describing, which is we support particularly those schools where we know children are at higher risk of tooth decay with things like supervised toothbrushing. And that is a much more effective and evidence-based programme than the school checks. So it was stopped for a good reason. And for that reason, it is not the solution, and it is not going to be continued or restarted. Separate to that, we do have dentists going into schools to do a survey every other year of 5-year-old children, where we look at the state of children's teeth, but that is an epidemiological survey. It is not a check for the child.
Thank you, that's interesting. Thank you.
Thank you. Any further questions from members of the committee? Okay, thank you. In which case, we've considered the information presented to us today on NHS dental services in Lincolnshire. So I should like to move to a proposal as follows. One, that the presenters be thanked for their presentation on NHS dental services and for answering the committee's questions. 2, that the initiatives in Lincolnshire to improve dental health be noted. 3, that the committee receives a further report on NHS dental services in Lincolnshire after a period of 6 months. Do I have a seconder, please? Councillor Lee, thank you. All those in favour, please show. I think that's unanimous. Thank you very much. Thank you very much for attending. Thank you, Anna, online. Much appreciated. And we look forward to seeing you again in 6 months. That's a bit of a catchphrase, isn't it? Yeah. For a checkup, yes. Thank you. We are running ahead of time, committee, so I should like to propose that we take the work programme now, then take a break and be back at 11:15 for the GP item. Can I just have a show of hands for that? I'm told I need a show of hands to change the agenda. Thank you very much. So we'll now move on. Tracy, sorry to throw you in unexpectedly early. On the work programme, please.
Thank you very much, Chairman. So the committee's next meeting is on the 21st of January, where the committee will be receiving items in relation to the North Lincolnshire and Goole NHS Foundation Trust. This will be an introductory item on the work at the hospitals in Grimsby and Scunthorpe. There will also be an item on the Community Mental Health Hub and Community Connector model, and also an item on non-emergency patient transport. And also just to confirm from the last meeting the items that were requested, the item on community pharmacy that's listed on the 1st of April, that has now been confirmed by the officers as being able to present that. And the maternity and neonatal services equity and equality strategy has also been confirmed for the 13th of May agenda. And I've also listed the NHS planning for demographic changes for the 1st of July, but that's still waiting for confirmation. But otherwise, happy to take any suggestions, Chairman. Thank you.
Thank you. Thank you, Tracy. Any suggestions, any thoughts, any comments, members of the committee? Councillor Mackinson.
Well, it would be interesting. There's been lots this morning about caesarean sections have taken over from natural births, and it'd be interesting to hear a bit more about that, because I would have thought that was a lot more expensive for Lincolnshire.
Councillor Lee.
I think as people know, I'm very concerned about the potential impact of any change in service delivery to the One U Lincolnshire service. And I just wonder if this committee, Health Scrutiny, ought to be looking at the way that any changes post any decision at the budget in February might impact on GP provision and that sort of thing, because we've heard this morning about the impact on wider health, and I'm really not trying to make a political point here. I do think that this committee needs to look at that, about the impact more widely, should it happen. Thank you.
Okay, that's noted. Any other thoughts? Are you okay? Obviously, any thoughts are always welcome. Email Tracy or me, and we'll take them on board. Always happy to listen. So we are running ahead of time, unfortunately, unexpectedly. So if we can reassemble at 11:10, to give us 5 minutes just to get settled before our colleagues from the NHS come and we can discuss GP services. Thank you. Meeting suspended until 11:10. Okay, meeting reconvened at 11:12 to start again with item 6 on our agenda, which is GP services. Item 6 was circulated as part of the agenda pack on pages 59 to 65, and is our 6th monthly report on general practice provision in the county. As usual, we have 2 reports, one from the NHS Lincolnshire Integrated Care Board, which is found on pages 61 to 75. The second report is from the Lincolnshire Local Medical Committee on pages 76 to 85. The presenters joining us here in the chamber are Sarah Jane Mills, NHS Lincolnshire Integrated Care Board, and Dr. Reid Baker, Medical Director of the Lincolnshire Local Medical Committee. So firstly, I should like to invite them both to welcome them both and then invite them both to introduce their reports. If you'd like to go first, Sarah Jane, and then Dr. Baker to follow, and then we'll do questions after you've both given your presentations. Thank you.
Thank you, Councillor Cleaver. I won't go through the report line by line as you've had it circulated, and I'll assume that that you've had the opportunity to read it. I'll just highlight some particular points from my perspective. One, colleagues will be aware that the main focus of improvement across general practice has been with regards to access, and a lot of work has taken place over the last year and predating that, but in regard to the development of systems to improve that, most specifically making sure that there is same equity of access irrespective of whether somebody walks in, telephones or uses online consultation. With regards to Lincolnshire, the specifics with regards to online consultation, there are some technicalities that people have been working through. When I wrote this report, 84% of our practices were fully compliant with the requirement, which is exceptionally positive when I looked across other areas. In terms of phones, again, our GP practices have responded very constructively to the introduction of the iCloud system, which enables them to introduce different functions such as callback and queuing, call recording, and flexible configuration, which is particularly important in terms of business continuity. And we have had some incidents in recent months where a practice has had to divert their phones to colleagues as they've had floods or other issues, but also as a foundation for the general development of neighbourhood working, where practices will increasingly work together. In terms of one of the primary opportunities with regards to digital is something called GP Connect. So national policy and local plans have seen developments in community pharmacies and also in secondary care, where increasingly providers are working together and patients can access services. So for example, people can go to their community pharmacy for a whole range of things. The important thing is that information is shared with their GP practice, and that's both so that the information on the GP record is complete, but also enables the general practice to identify if there are any issues that need particularly following up. For example, if a patient has multiple UTIs, it might be that there's further investigation indicated, things such as that. I have highlighted and included in the report a practice issue. Colleagues will be aware that in September of this year, the CQC removed the registration of Spilsby surgery. That was a administrative process with regards to the requirements for registration. As a consequence, the ICB terminated the contract with immediate effect. Sadly, there was a period of disruption for patients, which was managed with the support of particularly our community pharmacy colleagues and urgent care during the week when patients weren't able to access the services at the practice. We've appointed a caretaker, which we did during that period of time. They were back in and up and running on the 6th of October, so there was just a week, and they've worked very, very hard to stabilise the services and ensure that the backlog of issues have all been addressed. We will be looking to complete a review with regards to the long-term arrangements for provision for those patients. One of the things that we've discussed quite a lot at this forum is with regards to patient experience and feedback. So in the report, I've included quite a lot of information about the mechanisms that we have both in Lincolnshire, but also supported by other colleagues, so Health Watch, who have done their own survey, and it's actually live again, I think, in terms of getting feedback from different sources. And then alongside that, we have information that flows into the ICB from the ONS Health Insight Survey, and that's a survey that's undertaken regularly. We bring all of that information together and we review it not just on an aggregated position, but also at a practice level. And we do note that there is variation. There's often reasons for that variation, and that might be local need, it might be recruitment, it might have been changes in systems, and then we work with those practices to address their issues and support them in terms of developing a plan. From that patient experience feedback, you can see that the themes that we've discussed here, but also the themes that are highlighted nationally, are consistent from our local, national and individual practice perspectives. Our GPO practices work very hard with us to address all of those. In terms of the CQC, again, I've included the information. We note, and we have noted at this meeting, that there is a backlog in terms of a lot of the practices haven't been recently assessed. So from an ICB perspective, our primary care quality team have developed a process called QEWS, which is the Quality Early Warning Score. And that enables us to work with the individual practices and to review the issues that would be looked at by the CQC and support practices in their improvement plans. That does two things. One, it provides us with the assurance in terms of the work that is happening at the practice, but the second is it supports the practice to understand the areas where they need to pay attention, both in terms of improving experience for patients and making sure the services are safe, but also in preparation for CQC assessment. I haven't put very much in regarding the primary care workforce because I am aware that you have got a second item from our colleagues across the system. I will be staying for that to answer any questions in terms of general practice. But in terms of just some headline figures for Lincolnshire in terms of GP numbers, we've got 454.79, very specific, so whole-time equivalents of GPs, and that is a change from 2015, where we had 377, and 2019, where we had 413. So you can see the number of GPs in the county is continuing to increase. We do see a change, and Dr. Baker might touch on this, we do see a change in terms of older GPs and particularly GP partners are reducing in number, and we are seeing an increase in GP salaried, but in terms of the GP workforce, we have seen that increase. And that's been supported by very good training opportunities and also the introduction of the general practice role as part of the additional roles reimbursement scheme, so the ARS scheme. In terms of estate, estate is a critical enabler, and it's one of the areas that we discuss most with colleagues in general practice in terms of as they've got both increased demand and increased workforce, the capacity for them to accommodate that. We're very pleased in Lincolnshire that we have a very proactive relationship with our district councils to secure as much Section 106 funding as we possibly can. And we've got funding available for 55 practices to progress estate development, and that's available as we speak today. There are others in the scheme. And from a Lincolnshire perspective, just under 1.4 million from national funding called the Fund, and that is supporting 29 practices to progress estates improvement. We are aware that that investment from a capital perspective will continue over the next 4 years, and we're just in the process of putting in plans associated to that. One of the big national focuses is the development of neighbourhood health. This isn't new in Lincolnshire. We've been working on this for a number of years, both in terms of the broader neighbourhood health, but particularly as part of our primary care network development. So we start from a very good place, but we will see that developing increasingly in the coming years. I've set out the principles in there, but just to give you some examples of some really, really good projects that are underway at the moment. We have something called the High Intensity User Rollout Programme. Now, High Intensity User is a term that's used for a number of different patient cohorts. In this instance, it is looking to support patients who have had 7 or more contacts with A&E, and we've rolled that out and tested it in a couple of our PCN areas, and now we're working on the programme to roll it out across the county. In general, with those interventions, and this is really at the heart of neighbourhood, what we have found with those patients is it's often not a medical need, and by medical I mean physical or mental health. It's often a broader support need. So it's how we then connect people into the services that can support them going forward, and that's one of the core elements of neighbourhood. Another example is frailty. 12 of our 14 PCNs, well, actually 13, are now actively on board, and they are looking at how they can support people living in their communities who are ageing, so growing older. How can we encourage them to take a proactive approach in terms of their general health and well-being? But then when they are identified from a clinical perspective, because frailty is a clinical diagnosis of having increased needs, how we work with those patients to proactively support. I think I've mentioned before about the primary care network pilots. We're really fortunate in Lincolnshire to be one of 7 ICBs working with the national team to look at how our PCNs and particularly our general practice can work together to develop the services. This has been an excellent opportunity for those practices in those 3 PCNs to come together to look at how they work to organise and put in additional service support for their patients. There's been a range of interventions that they have introduced. For example, one of them has introduced a same-day access hub, which means people who require urgent on-the-day access can be supported through that. But actually what that does do is release the capacity back in the practices for them to support in terms of continuity of care, which is the second area that patients highlight as being important to support them, and clinicians highlight in terms of job satisfaction, actually working with an individual to support them with their holistic care needs is particularly important. Through that pilot and in alongside work that Dr. Baker and colleagues are focused on in terms of interface, so this is about how our hospitals and our GPs work together. We're really seeing some progress in terms of how do we develop systems and processes that for all parties, so for patients, for general practice, and for our colleagues in secondary care, mean that we're not wasting time by unnecessary steps in a process. And Dr. Baker's at the heart of that, so I'm sure he will mention in there. And then the final area is in regards to multidisciplinary team working. So multidisciplinary team working is both at a practice level, at a primary care network level, but also with the broader colleagues in the health and care community. And that is an area that is continuing to develop. As part of that, Lincolnshire has been able to appoint an additional 458 whole-time equivalents working in hours roles, and I've listed some of those as part of the appendix. So in conclusion, from an ICB perspective, I'm very privileged to work with GP practices that are really committed to providing good services for their patients. We recognise that patient experience has highlighted some areas of improvement. They are consistent both with the national picture and the feedback from practices themselves. And our colleagues in general practice and primary care networks are working very, very closely together to address areas of variation in their local communities, which, as I say, is a critical part of the foundation for neighbourhood working. So I'll hand over to Dr. Baker.
Thank you. Good morning, Chair. Good morning, Committee. Thanks for having me here again. I'm going to keep it very brief because I've already submitted an extensive report with lots of allied documents, which I apologise for. So this is my apology to you by keeping it very brief now. So we've got plenty of chance to have a good discussion around the content. So as I've said before, and is in my report, we're working tirelessly as ever in general practice to try and meet the needs of our patients, providing new services, some of which Sarah Jane's outlined already. And we're still recording record levels of appointments, both locally in Lincolnshire, but also reflected nationally, despite all those challenges we've talked about before and new challenges that have come along. As you've seen from the report, activity data from September 2025 shows that we're delivering more appointments than we were in September 2024 and more than when we met last time in the summer, when it didn't feel quite as wintry and busy in the NHS and wider system than it is at the moment. You may have seen the headlines since in October. I'd done my report before they would publish, so apologies, that there was 40 million appointments across general practice nationally in October, which is a new record. And in Lincolnshire, we did 631,271, which equated to about 79% of the population of Lincolnshire having an appointment in general practice in just October. I've talked before at committee about all those pressures, but just to remind us all, you know, the real terms contractual funding decreases, national insurance rises, increases in national minimum wage, potential loss of some of the locally commissioned services, and talked about that more in my report in terms of the changing of the ICB structures and clustering in terms of what that might mean for us in Lincolnshire. Hospital waiting list pressures, which unfortunately, despite lots of good work across the system, is still really, really challenged. And of course, increasing patient demand and expectation with all the services that are available and are offered to our patients. So despite having the first agreed GP GMS contract we talked about briefly before, these pressures weren't relieved, and unfortunately, as I said, we've had additional pressures onto general practice. And you may have seen, and if not, I'm sure we'll talk about the 1st of October changes to online consultation tools. That increased demand on practices immediately, and also, unfortunately, has risked both patient and GP practice workforce well-being and safety. That challenge, along with other challenges and lack of progress on the promised new substantive GP contract by our current government, led to General Practice announcing dispute again with government on the 1st of October. Since we last met, we had the summer announcement of the NHS 10-year plan, and that's got both risk and opportunity potentially for our NHS, our patients, our population, and general practice. But unfortunately, as well as that, as I've said, clustering of ICBs and optimisation of services brings us unfortunate loss of organisational intelligence, local relationships, expertise like Sarah Jane and other colleagues across our Lincolnshire ICB who know our communities, our population and our general practice and primary care providers. I think while redesign and reform of services is at times extremely important, I feel now is a really difficult time for us to be going through that locally. And nationally, of course. But despite all those challenges, we've continued to deliver those levels that I talked about of increased activity and much above levels of comparable systems, both regionally and nationally. And we're still striving to produce that high quality service that patients expect and that we're promised. But we're also simultaneously raising our voice about the concerns for us as a profession, our practices and our population. And nationally and locally, we need to move forward with that. We need to do that to protect the population and our practices. And we need our profession and our government to work together to deliver that promised new contract. Because we need that to bring back the family doctor that government have promised in this Parliament. And that needs to provide those significant improvements for us, our practices and our population for our health, each and every one of us in this room. I'm going to leave it there for my intro today. I hope that was short enough and welcome lots of discussion.
Thank you both for your presentations. We now move to members' questions. Would members of the committee please indicate if they wish to speak? Thank you. I have Councillor Smith first, please.
Thank you, Chairman. I know GP practices across Lincolnshire are all working on such a shoestring. And when a patient is told by their local practice to go to their pharmacy to buy their dressings and bring them with them to their next appointment because that practice can't afford to give any more dressings to them, it's a sad situation in 2025. With the GPs losing so much money on non-attendance patients, I know that they can't implement a system of charging, which is a shame, unlike dentists, for missed appointments. Has the new telephone system of GP callback reduced the non-attendance for the practices to help them financially across the board? Thank you.
I don't have the data in terms of whether the new telephone system has reduced non-attendance. What I would say is in Lincolnshire, actually, our do not attends are relatively low compared with the national average. So generally, our patients are very good at booking an appointment and then turning up for the appointment. I think what has helped in a number of instances is for those people who have got an iPhone or equivalent, receiving a text to remind them I think that has helped. Whether it's the new telephone system, I don't think that specifically will have made a difference because that's about access to getting through for that. I do think that the prompts that people get now will have made a difference, but I don't know specifically what impact. But I can tell you that Lincolnshire's do not attends is lower than the national average.
So can I just come back on? Will you be able to collate information from that later, maybe next year, to see if there is a marked difference?
So it's something we monitor, and certainly I can ensure that in future reports we can say the comparison in terms of do not attends, so that you can see that visibility. It's really hard to say it's one thing because the other thing that in terms of the change in terms of how GP practices work, so not just the prompts, but the change in how they work in terms of booking appointments in advance and things like that. But yeah, we can bring that. I think just to say that, I'm sure Dr. Baker will correct me, but in terms of funding, the practice doesn't lose funding associated with a patient not attending. What it means is that appointment is lost for other people. And I think that is the bit that obviously when we're looking at the amount of pressure that practices are under in terms of meeting patient need, anything that means that we've had an appointment that could have been used for somebody else is a loss for patients, which I think in the current climate is a real shame.
Dr. Baker.
Thanks. Yeah, just to, so Jane touched upon some of it, but just to build on it. So I think in DNAs there are a lot more avenues that practices contact patients to remind them, definitely, both with text messages, but also NHS app is great there, and also great for patients to cancel. I think what will be really interesting is because of the changes of the 1st of October with that ability to book routine and further to the future, and as I've talked about already, we've got waiting lists and so on and so forth. What we've seen traditionally pre-COVID was the longer the waiting list to see a GP practice for an appointment, the more DNAs you get. So we might see an upswing again, although what we've got since then developed more robustly are those mechanisms to contact patients to remind them. But it is going to be important that we do remind patients more and more and more as these access points change over time. In terms of the funding, we don't lose any funding as a result of that. But when we talk about access, it's clearly key that we optimise it as much as possible because we're still paying those staff members and the cost of running the practice. So it's having a value of that appointment, isn't it, once you've got it, which is key, I think, and we need to use it as best as possible.
Thank you. Councillor Kendrick next, please.
Thank you, Chairman. Councillor Smith actually asked a question about DNAs that I might have asked. But I want to know, and I may have missed it in the report, and I apologise if I have missed it. I know we had discussion at a previous meeting about paramedics being involved in GP practices. It brought to mind because when I went for my flu jab, it was a former paramedic that actually gave me my jab. And I was just wondering how that's working across the county in terms of either currently serving or former serving paramedics being engaged in GP practices. Thank you, Chairman.
So the ability to employ a paramedic is something that GP practices have explored increasingly, particularly to support home visiting. So I know a number of practices who've got a paramedic working as part of their GP practice team to support home visiting. And I know from those practices that they feel that that works particularly well for them in a multidisciplinary team capacity. And similarly, for a number of initiatives under primary care networks, people can explore employing paramedics to help them in that broader services. So from a general practice point of view, I think it adds value to that multidisciplinary team, and paramedics have a skill, particularly of visiting people in their own home, making a comprehensive assessment and diagnosis and determining what treatment plan it needs. So from a general practice point of view, the feedback we've had is it's really positive. There's obviously an equal and opposite in terms of the ambulance service and whether there is any negative impact of people looking to take up roles in general practice. I think increasingly what we hear from not just paramedics but from GP colleagues and from nursing colleagues that from a career perspective, actually having opportunities to work in different places can be really, really positive and can actually help retention in terms of those professionals in the health service. So I think whilst you could see, oh, this is a negative for EMAS, for example, actually I would say if you look at it from a workforce perspective, it's a positive because it gives people broader opportunities in terms of their own personal career. And we are hearing that from a retention point of view, people want those opportunities. So I think it's a bit of a difficult picture, but certainly from a general practice perspective, the GPs that have got paramedics working as part of their team are very positive about it as a contribution to their MDT working.
Thank you. I have Councillor Martin next, please.
Thank you, Chairman. Something I've always been interested in with a lot of people we talk to is the patient journey, how the process through the GP or straight to the UTC, A&E and into hospitals. You say here on page 66, it says A&E and UTCs are overused due to poor GP access and lack of same-day care. I was just wondering, do you have any statistics to show how many people actually have go straight to the A&E or the UTC without the GP? Because it's just something that obviously it's a major concern for many people, and it'd just be interesting to know where what sort of numbers they actually are. Do you want to?
It's very hard to get the actual numbers, because what that would do is we would have to sort of like stand at the front door, if you like, and say to patients, you know, have you tried your GP first? Have you, and all the rest of it. And we have done that in the past. I think one of the challenges is patient perception. So with a lot of, if you like, discussion in the media around challenges of accessing GP, it becomes almost a bit of a self-fulfilling prophecy. And some patients, and we do know this, some patients don't even try their GP practice. They go straight to A&E or urgent care. Not all patients, but some do. In the majority of instances, and particularly, and again, I'll defer to Dr. Baker, but with the introduction of triage and the way that practices work, if a patient contacts the practice and needs an urgent appointment, the practice do everything they possibly can to facilitate that. And I rarely hear a practice say, no, we've turned off and everybody's got to go to urgent care. If that is a scenario, actually there's a formal mechanism of a practice contacting us to say we've got a capacity constraint, and that could be the practice themselves have got a number of staff with flu, and we have a mechanism for how we manage that. In the main, GP practices do exceptionally well of addressing the need that comes through their door, but it is the challenge of patient perception. Oh, I can't get a GP appointment, so I'll go to urgent care. I think there is also, and we do monitor this in terms of, if you live closer to an urgent care centre, there is a higher probability that you will go to an urgent care centre. It's not always the case, but if you live in the middle of, so where I live, if you live in the middle of the East Coast, actually I'm more likely to try my GP practice and get an appointment through that than I am to either go to an urgent treatment centre or a pharmacist, because I've got to travel a considerable distance for that. But capturing the numbers of it specifically is very, very hard. We do monitor where patients come from who use urgent care centres. So I can tell you this practice has more patient going to this urgent care centre. Why they've gone there is hard to actually get behind. But we've done some of that, again, with Health Watch in terms of some of the surveys we've done actually in those centres.
Dr. Baker.
So, if they might want to come back on the point. I think Sarah Jane's right. You know, there is a lot around perception here in terms of could you get access to your GP practice in the first place. And obviously we've heard that there's more access points and more activity than ever. And now from the 1st of October, you can book more and more routine things. But of course, patients might feel that they have an urgent problem. And that may be urgent clinically and it may not. And that's where we sometimes have a little bit of a challenge around what we clinically think is urgent and what a patient may perceive as urgent. And again, that's about supporting and educating our population, and also us getting the same information to make that judgment call. I think a good example of when people might transition from general practice into UTC and ED is a classic example, and I'm quite well renowned for being quite stringent with when I give antibiotics out and when I don't, is if I say someone has a viral illness and all the indicators are that that is the case in someone, and yet they feel they need antibiotics. And I spend quite a lot of time discussing that with patients, which I hope is valuable, but patients may still attend a UTC, ED or call 111 feeling that they need antibiotics, because everyone's worried about being poorly at the end of the day and they want to get better as quickly as possible. So sometimes people will turn up in a secondary setting as a result of that, be that UTC or ED. And other times, rarely it does happen, but it does happen. Patients will just say they haven't been able to speak to their GP, etc., and yet they will have had a phone call or a face-to-face appointment. And again, that's data tracking, isn't it? And part of the NHS 10-year plan is all about that single patient record, and that would be visible. Some things are visible currently. I think proximity was exactly what I was going to say. All the data says if you are close to a UTC or ED, you will turn up there. And as a patient, whether you think you can get an appointment in your GP practice locally or not, I guess there's probably an element of, well, if I go to a UTC or an ED, I'm probably going to get all the tests that I need there and then, whereas a GP, I'm going to have to refer for a chest x-ray and so on and so forth. So again, there's a little bit about that one-stop shop, and that's not necessarily how we should be thinking about our UTCs and EDs, but we want to get things done quickly. And I always say about, Amazon is caused as a problem in society, hasn't it? Because we all want things much more quickly. But again, when we are concerned about our health, we want to be treated quickly. I think in terms of data sets, I think we can have some more robust data going forward. I think, off the top of my head, I think if people perceive they can't get in at their GP practice or contact from a GP practice, I think 6.6% would then attend ED or a UTC setting, which doesn't sound a lot, but it obviously is quite a lot of people. But just in terms of activity levels, you don't need much of a change in general practice to cause a significant impact on ED and UTC. Because we do about 400 million appointments a year, UTCs and EDs do about 30 million, 1% less general practice activity would be about 13% increase in ED UTC activity. So it doesn't take much, and that's why that can feel like a big swing, if that makes sense.
Thank you for that. Councillor Martin, you want to come back?
Yeah, can I just ask another question? Is that okay?
No, I've got other people in the queue, and then I'll come back to you. Okay. That's okay. Councillor Lee, please.
I don't mind, Sheriff Councillor Martin, because it is horrible if you lose your train. Honestly, go.
Thank you, Councillor Lee.
Okay, it's a fairly quick one, this, I hope. Just referring to estates, okay. With the shift to online services and such like, I just wondered whether there was a change in the size of the building requirements, the actual structures that are needed by GPs. And this kind of leads on to development, because in Grantham, over the next 20 years, we're due 50+% growth in the town. Is going to be huge. Many thousands of new houses. And there's money locked up in those S106 agreements, as you were saying. I mean, we've currently got a thing where a new chart, if you like, we've been given by the District Council, says there's £223,000 in a pot waiting to be allocated to some kind of health-related service. The developer I know who is related to a lot of that money, and we're talking up to £1.3 million, has told me that in their view, and from what they've discussed, they've been told that that money's not required, and they're not going to build the health centre, etc., they're supposed to be building. So the question I have is, with all this money and such, like, especially in Grantham with huge developments going on, are you keeping a close eye on where this money is? And is there any option there for you to change the S106 requirements? Have you actually spoken to the district councils to see if there's ways of unlocking it and using it more for your services or for even preventative services? Thank you.
Thank you. So in answer to your first question, which is what's the impact of online on a state, online gives greater flexibility with regards to where staff can work. So online tools and capability may mean that certain functions don't actually have to sit at the GP practice. And for some clinicians, maybe they don't have to sit at the GP practice because they're doing the remote. So it gives you greater flexibility in terms of where people are locating, which in return releases a state for them to see patients, because although we've got the tools, as we've talked about, the demand for GP services is increasing, and we expect it to increase, both because of the demographics of our local population and the fact that people are older and likely to have more long-term conditions. So there's a sort of like increased demand associated to that and our local population need. But there is also an increased demand as we start to develop neighbourhood working, and services are moved out of hospital into community. So we've got the twofold. That means that from both a workforce but also from an estate perspective, we constantly need to make sure that the right facilities are available to do clinical treatments, and that's where online tools gives us a mechanism for releasing some of that estate. In terms of the Section 106, we have a very, very structured process. So one of my colleagues tracks literally every bit of Section 106 money, and we respond to every opportunity. So when you're talking about there's 236,000 potentially available, there's a couple of things. One is, whilst the money may have been allocated, it isn't released until particular triggers are met, and that's really difficult because actually we don't get the funding, the capital funding, until people have moved into the houses, by which time they're needing the service. So there is a bit of a flaw in the process of that. The second is that often the perception is we need to build another health centre, or we need to build another GP services. Actually, in many cases, not in all cases, it's about enhancing the estate that we already have. Now, in some locations, we are constrained because there's basically the estate is locked. There's nowhere that you can develop it, despite some really, really creative architects that do manage to use land that we didn't think would be possible. So Monks Road is a really, really good example of an estate that we thought could never be expanded, and actually with some very, very clever architectural work, they were able to increase the capacity quite a lot there. In terms of the specifics, where we've got big, big housing developments, our teams are actively involved, both in terms of working with the planners, but also working with our local practices. And this is where the opportunity around primary care networks becomes, and neighbourhood working becomes a sort of like opportunity in terms of, do you extend a state, not by building GP practices, but by building perhaps facilities that others, like a physio, can see somebody, etc., etc. And we do have that dialogue consistently with local planners. And we try as far as possible to keep a flexibility when we make a Section 106 application. So if a housing development would be covered by a catchment area of, let's say, 3 or 4 practices, our submission will reference those 3 or 4 practices. Then we work with those practices to determine, well, where are the patients actually going to, and where do we need the state capacity. So as far as we can, we do as much as we can to maximise the Section 106 funding. Different district councils work with us in different ways, and one of my colleagues, a lady called Jackie Bunce, is very connected with them to explore how can we be a bit more innovative in terms of using Section 106 money to actually support local services. But the rules are quite they're quite rigid, and the mechanisms are quite rigid. But just to provide, you know, and repeat, we've got really, really good visibility of all of the developments, and all of those where we have had the opportunity for, we have put in for additional capital. And I think that's the other thing. This is about capital funding, and often capital is great, but you need the services to sit alongside it. It's great building a building, but if I've got no GPs and no nurses and all the rest of it, it's not of any value to people. So it's quite a complicated situation, but we've got a good grip on it.
Thank you for that. Councillor, Dr. Baker, you want to come in on that as
Thanks,
well?
yeah, just on both of those points, hopefully to add a little bit as well. So I think in terms of estates, has online helped with, you know, the estates need that we have? I think, unfortunately, it hasn't. While it's given more options, and I know Sarah Jane said some of this, as we talked about in the reports and in previous committees, because we've got an increasing population, increasing complexity and medical conditions, more appointments generally, but more per person. We've increased the total number of appointments. So proportionally, we've got more remote options, let's say, but total need of face-to-face in-person has still gone up. And coupled with that, obviously, we've had the national demands of, you know, from government and media of more face-to-face. And patients seem to value that a lot. Large cohort of patients value that above other consultation modes. So overall, there's still a net need for more estates. 106, Section 106 is personally one of my big challenges, and we've talked about it before at this committee, and the challenge around it being capital and not more GPs, because you know, you sometimes see comments where if there is a big housing estate built, that the existing residents before the new estate is built saying, "I'll get more GPs or nurses or teachers or whatever," and that's what we'd all love to do, but it doesn't come hand in hand. And I think last time, and I can't remember the number, I worked out quickly on the back of a piece of paper, didn't I, how many more patients you would need to be able to fund another GP and another nurse in a practice, and it was a lot. Yeah. So that's the challenge, because it still doesn't meet demand. And on that point around the estates themselves, you know, the challenge is, and I think I put it in the report, you know, 22% of estates across the country are pre-Second World War GP surgeries. That aligns with what Sarah Jane was saying. There's just no ability to change some of those buildings. My old practice, we got architects in, and because of the way it was configured in the spot it was in, there wasn't much we could do, and what we could do had to have some innovative foundations, which comes with pounds signed. And that goes to my last point. If the Section 106 money doesn't go anywhere near meeting the cost of those changes, I think if I remember correctly, it would have been a 7 or 8 times higher cost of build than the Section 106 would have cost us. So yeah, I'll stop there.
Thank you for that. Councillor Lee, thank you.
Thank you, Chair. I'll try not to be too long, but I have got a number of points. It's interesting. I wasn't even going to talk about Section 106 money, but we've got a particularly hideous development being proposed near to where I live. And part of that includes a contribution of Section... for all the reasons you've said, like the time lag between getting the money, and also I'm not convinced the money will actually be spent in our area. We're going to have like an extra 200 or 300 people, but it's a whole part of it, so I feel your pain there. My second point, page 83, the NHS plan, 10-year plan, point 6, talks again about preventative health care, preventative measures, and I feel as if I'm the only one that's jumping up and down about this, but this council is looking at potentially diverting, and it was in an agenda, potentially spending some of the money that's not spent at the moment on public health and using it on other council priority areas. I'm horrified by that, because you look at prevention of things like diabetes and heart disease, and the reason I mention it here is because it's got to have an impact on GP services. I mean, I think it'll have an impact on the costs of our social care, because people will get sick younger and need looking after, but I've asked for it to come back to this committee, because if that happens, it will impact on GP services in Lincolnshire if we haven't got the same level of preventative care. I wanted to say, you mentioned on page 85 about GP strike action. I absolutely, people need to realise that people only go on strike as a very last measure when they're absolutely frustrated and there's no other way out of it. as a nurse, I was faced with this choice, and I personally, it always happened when I'd been on a night shift and I didn't feel like, having done 12.5 hours, the last 30 minutes I could walk out at handover. So I just stayed and just kept very quiet about it. But I understand why GPs went on strike, and I understand why the resident doctors are going on strike, and I totally disagree with Wes Streeting's perspective on it. I think if this country wants a quality NHS, they've got to fund it properly, and that's the bottom line. We've got to pay people what it costs. It doesn't come cheap. And just finally, some comments from a personal perspective about accessing the GP. I've never really used my GP apart from when the kids were young, but now I'm waiting for a knee replacement. I've used them a lot. I've found that, especially given the challenges of COVID and recovering from that, I just think it's got better in leaps and bounds. It's not perfect. It's not perfect by any means, but it's much, much better. As someone who's getting on a bit, I was a bit opposed to going to a physio instead of going to the doctor, but it works. I go to the pharmacist for my flu jab. I don't go to the GP. So it does work, and it spreads the loads, and it means that someone else can have an appointment instead of me taking up their time. And in terms of the interface between GPs and hospitals, I've got a date for my procedure now, and having gone against every principle in my body and accepted going via a private hospital as an NHS patient, I'm getting it done within 4 months, which I think is superb. So I think there's a lot that we could put right within our NHS, but I tell you what, there's a lot that's already right. So thank you for everything, and thank you for a really good report.
I don't think I can comment on any of those in terms of obviously decisions that the county council make is for them. GP strike is for colleagues, and it's just really good to hear feedback in terms of we recognise it's not perfect, but actually the effort that people are going to across the system is being experienced from a patient perspective to improve. So I think that's really good feedback. Thank you.
Thank you. Thanks, Councillor Lee. And once again, good luck with the knee replacement when you have it. It is great to hear really positive words, because I think we think long and hard about coming to this committee and all the challenges that we face across general practice. And as Sarah Jane says, we're not perfect, but we are trying really, really, really hard in general practice. So great to hear that. Clearly, we hear things that are still challenged, and we'll continue to work on those, despite the challenges that we're facing delivering to patients. I completely agree. We need preventative health. That was one thing general practice said on the NHS 10-year plan. We support that. That is what we need to be doing, because we're reactive at the moment as an NHS, and we need to be proactive. And to be fair, general practice say that's what we do best. If I'm having a heart attack, I'd much rather see a cardiologist than go to my GP practice. But if I'm worried about something and I need some advice and some preventative care, general practice and some community assets are where we need to be. So that's a welcome shift. How we do that is the next bigger step, isn't it, once we've agreed with that? Just to clarify GP strike action, so firstly, we have to take that word. We don't use the word strike because obviously that's not what we've done. We had collective action last year, and we're looking at what dispute means at the moment with government. Clearly there are strikes in terms of literally currently with the resident doctors, but GPs and obviously BMA, GPC England have been talking to government for quite some time and avoided any action as much as possible because we wanted to work constructively, and that promise of a new contract was why we agreed to this current contract, because we want those reforms that bring that high quality, sustainable, safe general practice that we can all work within safely and happily, and our patients get excellent care from. So what anything will look like is yet to be determined. I don't think I said last time, I'm now a member of GPC England for East Yorkshire, North Lincolnshire and Lincolnshire. So obviously I'm directly linked into those conversations. So what will happen is to be decided. But what I want to be clear on is general practice, much like the resident doctors, care so deeply for our patients. We wouldn't be doing this, you're quite right. We wouldn't even be having these conversations if it wasn't that we knew that something fundamentally was needed to change with as the system is at the moment. Be that funding, be the way it all works, be it the estates, be it everything. So we'll see what happens in that respect. I think you're quite right. Again, going back to my point about cardiologists, and I think I said it before, you go see a first contact physiotherapist. They are brilliant. They can directly treat you. They can refer you off for everything. And at least me, as I've said before, other GP colleagues may be different and probably are different. You're much better seeing a first contact physio than me. I'm much better at looking after your polymorbidity and complex medical needs. The only other thing that it reminded me of was just going back to that access around paramedics, etc. Is what it reminded me was that what we probably just need to be aware of and cognizant of is that as we increase access, and some of our paramedic colleagues might be seeing some of that self-limiting illness and minor illness, as we call it in general practice, it leaves the more complex patients for me and my colleagues. So what we need to be aware of is we shouldn't also be in parallel pushing GPs to do more and more appointments, because actually we're going to be dealing with the really difficult things, complex things that need 20-30 minutes, which is not what general practice has ever operated on. So that's, in terms of the access agenda, we just need to be aware of that, because those quick sore ears, sore throat, etc. used to be what caught us up on the time, and you won't be sitting for 45 minutes in the waiting room waiting to see me, because I'd have caught up with those, but we won't be getting those so much now. So just to be aware as an extra point. Thank you.
Thank you, Dr. Baker. Any other members of the committee have any questions? Councillor Mackinson-Saunders.
Thank you. I'd like to put on record Louth's thanks in particular to Sarah Jane. She did run our hospital really well for a number of years, and it's so sad to see your expertise will be lost when we become a joint ICB. And so thank you for everything that you've done for us. Going back onto the hospital, it's always been an idea in Louth that we've got 2 GP practices and we've got so much spare capacity up on the hospital side. Why we can't, with neighbourhood teams, then institute a big health centre for the whole of the town. I don't know how you get those wheels in motion, and it would work really well. There's parking there, there's all the diagnostics around and all the rest of it. But those are ideas which I could see really working, but I don't know where you'd take those ideas to. But it's, to us, it's a way forward, and we're a growing town, but not growing like Grantham, obviously. But and it ought to work quite well for our populations and for the villages on the outside coming in as well. But thank you very much indeed, Sarah Jane. We've all been very grateful. Whatever you do next, good luck. Thank you.
Thank you, Sarah Jane.
Yes, thank you, Jill. You and I have worked together for a very long time. In regards to estate, I think this is where it is so complicated, because you look at it from a logical perspective and you would come to the conclusion that Councillor Mackinson-Saunders has said, particularly in the Louth area. The complexity is the level of capital investment that would be required to build that is not available currently, and so that is one big challenge. And then the other big challenge, the estate is all owned by different people. So the GP practices will have individual arrangements, the hospital is owned by somebody else. So the logic, absolutely, I would concur with you. And knowing the Louth Hospital site as I do, it is absolutely begging out for that sort of design and facility. The reality of the complexity behind it is that it's unlikely that that will be sort of like achieved, although as part of the discussions around neighbourhood health development, there are discussions about whether there should be neighbourhood health centres. And again, even if you go, that is exceptionally logical, you've got so many people that you would need to get lined up, and agreement and all the rest of it. So I can't disagree. I just understand the complexity, and specifically the level, going back to what Dr. Baker said, in terms of the level of funding that is required to do even small developments is disproportionately greater than the level of funding that is available, even if we amalgamate all the different pots. And where we have got some brilliant developments. They have been sponsored, supported, facilitated by external funders. So the Carlton Centre and the Glebe is a really good example of that.
Thank you for that, Sarah Jane. Dr. Baker, you want to come on that one?
Yeah, just one quick point to add to what Sarah Jane said, agreeing with all the comments. I think the challenges in the 10-year plan as well, it talks about those hubs, etc. But as we know, there's been no funding aligned to that plan to date for any of the work involved within it. And as we just heard, the cost just for the estates alone, I think GP Estates was valued at 4.5 billion the last time it was put together. That's without building any new facilities that might be fit for purpose for the modern era. So that's the big challenge. Again, what gets off the paper of the 10-year plan and comes into a reality, there's some big numbers just for the estates.
Thank you. Anyone else wish to come in? In which case I have a few questions of my own, if I may. Sarah Jane, in your paper, you very helpfully mentioned patient participation groups, which is lovely to see. Can you just assure us that every single one of the 81 GP practices in the county actually do have an operating PPG? And are you satisfied that they all have good relationships with the practices and they are working as effectively as they can?
No, I can't give you the assurance that all 81 have a patient participation group. Largely, that is because of identifying people who want to be part of the patient participation group. It is not, the practice is not engaged. It's more about identifying people who want to be part of it. And I think, again, in terms of the relationship between patient participation groups and the practice, it's fair to say they vary quite considerably for different reasons. I can think of one patient participation group that is very, very active, not only in terms of supporting the practice and the patients, but active in lobbying for that patient, for that practice. And I can think of other practices where the patient participation group is a group of people who come together and feed back to the practice and practice take on board, but whether they do more than that is again limited to the people who are part of that patient participation group. From a ICB perspective, Claire Hornsby is one of, she's part of the comms engagement team but assigned to primary care, works with her colleagues very, very hard. In fact, I was at the patient participation group council meeting last week to bring people together to look at how we can support, and works very hard in terms of trying to stimulate interest and support practices in establishing their patient participation group. But no, it's not uniform, there is variation.
Thank you for that. Dr. Baker, do you want to comment on that at all?
I wasn't going to put my hand up for once, but yeah, I think it does vary. That's the thing. Engagement is a challenge. You know, we found that in my old practice. You are more likely to get certain cohorts attend, be that people who are positively supportive of the practice, or maybe conversely have some challenges with the practice. And actually that should be welcome, because that can show, you know, there might be something that as providers we don't notice that we could improve. So that is really, really helpful. But getting that engagement is really difficult, particularly younger cohorts. A lot of PPGs struggle to get younger people involved. And I guess that comes down to what's the benefit for those individuals to join a PPG? What do they see as, both personally and from the whole patient cohort, what they want to achieve? And from a practice perspective, what's the flexibility of the practice to be able to take on board those conversations and change the services? Bear in mind some of the challenges we talked about. But I think it's great value. I mean, as unfortunately for some people in the room know, I'm more than happy to talk to PPGs and people on an individual basis. But I think getting that message out to PPGs about the challenges for practices and then actually working positively is the key for me, while highlighting those things that we can change if it's within our gift to do so. So I'd love for more work to be on PPGs.
Thank you. The next question is about QEWS, Quality Early Warning System. Which I was, again, glad to see so much about that in your report. Obviously, we still have 10% of our practices who are technically, or on paper at least, shown as requirement in their CQC rating. So obviously this is an important issue, isn't it? That you have an early warning system that is active and well resourced to make sure that those quality issues are minimised across the county. So obviously there is a concern with the clustering that resource will be available in the context of the 50% reduction in ICB funding. Can you give us any reassurance about that, please, Sarah Jane? I know I put you on the spot there.
No, very, very good question. It is certainly from a Lincolnshire perspective and from my perspective, the reconfiguration that Martin, who is the chief nurse, did with his team, which identified a dedicated group of colleagues from the quality team that work with primary care, transformed our ability to support practices and get that assurance. So it's a model that I'm a great advocate of, and I hope I do get positive feedback from practices, but I hope it's something that the practices value as well, because it's a dynamic relationship, and that team work very closely with practices to support them to address the specific issues in that practice, but also share learning, because I think that's particularly important in terms of quality. In terms of the future, what I do know is that the scheme, if you like, the CUES scheme, is something that we have shared not just with our colleagues in Nottingham and Derby, but across the region, and it is something that is commended in terms of an approach to supporting quality improvement and supporting practices in terms of achieving that, but also for us in terms of assurance. In terms of any guarantees about the level of capacity, I can't give you any guarantees. As you've described, the challenge for the ICB is that they have to reduce the size of their workforce by approximately 50%, and that will impact across the board. One of the things that I think is important is as we go through, the changes to the ICB are part of a broader NHS sort of like change, if you like, and ambition. And so one of the things is, how do we explore opportunity for general practice, perhaps to do some of these things and develop the mechanisms themselves to have something similar. So it's unclear at the moment. It's a part of the transition. It's part of the development. This isn't just a cut the ICB. The ICB reconfiguration is part of that wider. And in Lincolnshire, I would say this, I think our colleagues in general practice, our primary care networks, and colleagues from the LMC have responded to the structural changes to start to consider how they will work together in going forward as if I can describe it more as a provider network. So some of those functions, perhaps some of the development functions, might be something that they collectively think about how they do, and that would then sit alongside sort of like the assurance. But in terms of guarantees, no, I can't give you any guarantees.
Thank you for your reply. Dr. Baker, you want to come in as well?
Thank you. Yeah, I would echo the feedback we get from practices that CUES is very useful. I think the caveat there is obviously, like anything that you bolt into a practice, is having the capacity to engage with it. And in a challenged general practice, that is difficult because it is intensive, isn't it, for practices? But they do achieve very well, and they've done well. Allied to that, and I think I've said before, one of our team, particularly at the LMC, is very CQC focused for practices, and again mirrors a lot of the CUES work that's going on from an ICB perspective. And so not in his entire role is that, but most of his role, bless him, is that. If we could clone him, we definitely would, multiple times, because I think he'd be invaluable to practice across. I'm not endorsing that, by the way, cloning, for this purpose. So it is really, really valuable. I think clearly that will continue no matter what happens, but that is one person. And I think, as Sarah Jane says, some of that development and support work might be from a different provider going forward. And yes, as you know, as an LMC, we're having conversations with the LMCs from Derbyshire and Nottinghamshire about what we're all providing currently, what crossover there is, and what we can share resource and understanding about. So it is crucial, though, because we need that quality to continue for practices and patients, don't we? So we'll watch this space.
Thank you. One final question from me about commissioning, because Dr. Baker, you mentioned the need to have a far better national GP contract. One of the things about the GP contract is the rules that it sets within which your practices are commissioned by ICBs. And I wonder, because Lincolnshire, we keep hearing and we know geographically is different from most of England, very much so. So it begs the question, doesn't it, as to whether any new contract should have a permissive element which allows flexibility locally for a local ICB to say, well, if you want to be commissioned to serve Skegness or Stamford or Lincoln, we want you to have this in your contract, it is binding, rather than have it almost hanging in the air as something, what you could do, you couldn't do, but it's down to you to negotiate at the point at which the service is required, if you see what I mean. Because we have lots of things where GPs at the moment can opt in or opt out, such as vaccinations, for example. Would it not be better if that is done as a local deal within each GP's contract on perhaps a rolling 2-year basis even? I'd be interested to hear if you think that would help Lincolnshire particularly.
Good question. I'm letting that percolate through my head while I speak, so it might be a slightly unformed answer, so apologies if I interject with things as I go along. So there might be some use in that if we want population coverage of all these services. I think just in terms of that, around vaccinations and the other enhanced or additional services as you talk about, the key there, and we've talked about it before, haven't we, with those services, is it needs to be done in a way that is viable, because otherwise the risk is they don't get delivered, and that's what we see with locally commissioned services, or at least some of at the moment. I think we do need something, and that's recognised not just for Lincolnshire but for other parts that are challenged in terms of the rurality infrastructure and population demographics. We need something that is fit for purpose from a contractual perspective for Lincolnshire residents. And part of the work that's been going on for population health gives us some of that intelligence that should inform those national discussions around contracts as to what we need. You may have also seen, GP funding is based on the Carr-Hill formula, and there's a current reworking of that formula underway, and some of the analysis of the Carr-Hill formula it was developed on data that's 25 years old. So populations, disease, etc. have changed significantly, as has infrastructure, cost of delivery, so on and so forth. So there's a lot of work going in, and BMA, GPs England have fed in a lot of information about what we think might be useful going forward. So that might help some of it, because if you enable us based on the demographics and needs and workforce pressures in Lincolnshire to have funding model linked to a contract that is reflective of what we need in Lincolnshire, we're much more likely to get where you want to get. The slight challenge at the moment, in case you aren't aware, is the Carr-Hill formula. GPC England are not currently being involved in those discussions, so we're not getting that expertise and intelligence informing the discussion day in, day out. So I think we should all be slightly worried if that continues.
I think it is a really good question, and it's probably one for a longer debate and discussion. I always see this in different component parts. So there is an important, and I think the contract this year has illustrated that all patients should have the confidence that their GP services provide a set of services. And actually the GP contract does provide that sort of like framework, if you like. And GP practices then have the flexibility in terms of how they organise themselves in terms of delivering that. Although increasingly, as we've talked about, there is alongside that expectation for all patients, there is then the sort of like follow-up in terms of, and that might include you've got to have walk-in, phone, online. In some areas, GP colleagues might say, well, my population are never going to use online. Why am I putting that in? But there is something about a national, everybody should understand that this is what a GP service provides. The next bit, I think, is where it becomes really, really, really complicated, in terms of, depending on your location, will influence what alternatives. So if you are in the centre of Louth, just using that, actually there are numerous pharmacies, for example, and you can utilise. If you are in a rural community, it's unlikely you've got a pharmacy. And that's when I think it becomes really complicated, because for that GP practice, then it's, well, how do I meet the needs of my population? And so it's possible that actually we're asking some of those GP practices in those rural communities, or trying to encourage them to do more in terms of things like vaccinations, for example. But it's a localised discussion and decision. There are some things which are part of the sort of like contractual structure, and we've talked before about dispensing, for example. So a high proportion of our practices are dispensing. So there are some contractual frameworks that enable us to do that variation to reflect the population need. The other element, I increasingly have this discussion, is around the primary care networks and the neighbourhood working. And again, we're waiting for the guidance, and we're waiting for the commissioning framework or the contractual framework for that. But that is the opportunity, really, to start to create the flexibility for providers, not just general practice, to really look at the needs of their populations and to design services in a way that works for those populations. And I just use this for illustrative purposes. But if you were on the East Coast, a high proportion of those living on the East Coast have long-term conditions, diabetes, CVD, all of those things. So in terms of access and the configuration of that community team, you would hope that they would have that skill set and that competence to reflect that population need as part of their core team. If you're in the middle of Stamford, actually the needs of the population might be very different. So it may be in that core team, you don't need all of those things, but what your patients need is easy access. So you might buddy with the PCN next door, and they've got the diabetes nurse, but actually once a week they come and work in your area. I'm hoping, but we don't know yet, whether that the neighbourhood and the primary care network framework will be complementary to the sort of like, if you like, the core foundation of general practice. That becomes a really complicated commissioning model, but we're on that journey with the fact that, again, in Lincolnshire, and again, because of our GP practices engaging so positively with it, our population health management data gives us that visibility that from a strategic commissioning perspective, we've got the tools to get into that sort of debate. I don't think you'll ever get a national contract for general practice that will give you that level of flexibility, because I think there is the need to be confident that everybody accesses that core GP service. But there are other things that are complementary to it that hopefully might give that opportunity going forward.
Thank you. Dr. Baker, you want to quickly come back?
Yeah, just a few more thoughts. Again, rambling, so apologies. I think flexibility in both ways can be useful. We're really good at it in general, dynamic, and we're flexible. You know, we tend to make things work, and that's why we're in the situation we're in terms of the pressures, because we've just managed to somehow keep working, make it as efficient as possible. So it's to our own detriment we've been so good to a degree, and so therefore, you know, we welcome flexibility, but we need to be careful with it. I think, yeah, a patient should be able to expect a core set of deliverable services in general practice. And again, just reiterating my point earlier, that's much easier to do when things are financially viable. But as I was just writing down some of the services that maybe I would expect to see in my practice if I turned up. So, you know, most people would expect to get an ECG. So we'd need that commissioned service. So that might be part of the national offering. That makes sense to me. Phlebotomy, so I get taken blood tests. You'd expect that, and most do it. So, you know, that could be part of it. I think where it gets more complex, and this is where maybe you said your 2-year cycles, it becomes challenging, is one of the reasons that we're so challenging in general practice is if when a new initiative comes out as a pilot, it's for 3 months, 6 months, or a year. Well, if you've got to take on new staff to provide that service, and so the ones I was thinking about were spirometry and leg ulcers, for example, you've got to have a commitment that that's not a short cycle commitment, because then you've got a long-term workforce plan in your practice, and you know, PCNs, as Sarah Jane said, might have a particular specialist they can invest in longer term as well. So that's one of the keys with it. And I wrote down, it becomes a very complex commissioning model. Because you would still, despite those core offerings, you would still need that micro flexibility around local communities, and how that's done, I think, is more of a challenge. But I think it still goes back to my original point. It all needs to be viable, and then you'll probably get most services delivered. Because as I always say to Sarah Jane, if all locally commissioned services were viable in practice and they had a long-term commitment, they'd probably do them all. There might be the odd exception, but they'd probably do them all.
Thank you very much. Any other members of the committee want to comment or question on this item? If not, thank you to both of you for attending today and for your reports. So having considered the reports presented by NHS Lincolnshire Integrated Care Board and the Lincolnshire Local Medical Committee on GP provision, we move to a proposal. My proposal is as follows. 1, that the presenters be thanked for sharing information on the GP services and for answering the committee's questions. 2, that the committee records its support for the improvements in GP provision in Lincolnshire, but also records its concerns about the future resourcing of the QEWS scheme within the new clustered ICB. And 3, that a further report be requested after a period of 6 months. Do I have a seconder, please? Councillor Kendrick, thank you. All those in favour, please show. That's unanimous. Thank you very much. Thank you again, Dr. Baker and Sarah Jane. And a Merry Christmas to you both. Thank you.
Mr. Chairman, can we continue to be updated about what's happening about the ICBs? Because I think it's important that we follow that, oh, I hate the word journey.
I think you can take that as read. Thank you. So we now move on, hoping that our presenters are already online. They are, thank you. Just want to check. So the final item on the agenda today is the NHS Lincolnshire Workforce Update, which is item 7. It was circulated as part of the agenda pack on pages 87 to 114. The committee last received an update on the overall NHS workforce in May 2024, so this is the first time we're considering the matter in the new County Council term. The presenters, who are all online, are Claire Lowe, Group Chief People Officer, Lincolnshire Community and Hospitals NHS Group, Julie Stevens, Senior Workforce Lead, System Transformation, Lincolnshire Community Health Services NHS Trust, and Vicky Lightfoot, System Retention Lead, Lincolnshire Community Health Services NHS Trust. Sarah Jane is remaining in the chamber for this item. Thank you, Sarah Jane. Would you like to present the report, please?
Thank you, Chair. Good afternoon, Chair and councillors, and thank you for welcoming us to your session this afternoon. As you said, Chair, my name's Claire Lowe, and I'm the Group Chief People Officer for the acute and community part of the hospitals in Lincolnshire. I'll take the pack as read, if I may, Chair, but would like to offer some verbal key points to you this afternoon. I'm happy to take any questions as we either go through the verbal updates, Chair, or at the end of the session. From a Lincolnshire ICB perspective, obviously, colleagues, councillors and Chair, you'll be aware of the major NHS reforms that were announced in March 25 since the last time we were presenting to yourselves at Council. But from a workforce perspective in Lincolnshire, our strategic priorities remain the same as outlined in the People Plan for 25 and 26. So that surmises valuing our people, the health and well-being of our staff, supporting the equality and diversity agenda, flexible working, growing our people, so continued partnerships with our education providers and partnership arrangements there, leadership development, digital learning, continuing to develop our people, so how we work with our career pathways, blended learning and continual professional development, and how we retain our good people in our lovely sector of Lincolnshire, working with attraction strategies and stay and thrive and flexible careers. So I just wanted to give you some headlines in terms of the Lincolnshire workforce statistics, because I think these are quite powerful. So in terms of Lincolnshire NHS system workforce, we employ circa 40,000 members of staff. So this is a huge number of staff that provide care in all different elements of primary, secondary and third sector care across the Lincolnshire footprint. We do have a number of vacancy controls and measures in place, however, and that is to help us address a reduction in agency spend and bank spend, which is a national request that's been asked on all acute and community providers and healthcare and mental health in terms of managing workforce and temporary spend. However, saying that, primary care workforce is planned to grow to 3,100 by March 2026. From a social care workforce perspective, we have around 26,000 posts. However, we're seeing a high turnover of around 33%. So there's more work to be done on the retention agenda from our social care perspective. If I could now just turn more closely to the community, acute and mental health providers, I'd just like to offer council some further points of interest. I was listening with interest to the previous session, and obviously you'll be aware we are in the active strike action that's commenced from this morning. We are working hard across our healthcare setting to minimise the impact on our patients. However, we are experiencing, again, as what has been reported in the news, in terms of an increase in flu admissions, which is adding pressure to our hospitals. I just thought it would be useful to share with council the current flu vaccination programme and where we are from a staff perspective, because obviously we need to keep our staff well and at work to care for our patients. And across the Lincolnshire care groups, we're performing really well, with our uptake from a mental health perspective currently standing at 49.6% of the staff eligible for the vaccination. From a community perspective, we're standing at 53.5% of staff eligible for the vaccination. And an acute perspective, we're standing at 54.5%. So I'm really proud to be able to offer that as an update. And within the Midlands cluster, of which there is a league table, Lincolnshire is one of the highest in the league table for those uptake rates. We continue to work really closely with all of our vaccination programmes as that vaccination programme continues to be rolled out. Health and wellbeing support for our staff remains a huge priority, and whilst we've seen a reduction in sickness over the last year, we are seeing the usual spike, seasonal spike at this time of year, which is linked to coughs, cold, and indeed some of our staff with flu. So this does mirror the national picture, and we range from a sickness rate for our staff from 5.4% up to 6.7%. So across the workforce, we've implemented a number of employee assistance programmes which offer support with finances, fitness, mental health, psychological support, counselling services, which is open to staff and their family members. And we continue to work with the People Promise pillars, of which Lincolnshire has been congratulated on nationally during the last financial year. I think finally, council, I'd like to offer a provider update on the National Staff Survey, which just recently closed at the end of November. This is where a national mandate for all members of staff working within the NHS have the optional ability to fill in a staff survey. And early indications, council, show that we've grown our engagement in terms of more staff have filled that staff survey in, which is encouraging to hear. The results of the survey are expected to land early spring, so we will wait and see and obviously bring back an update to an appropriate scrutiny committee at that point in time, Chair. Without further ado, I'd like to pass to Julie Stevens, Chair, if I may, who'll offer you a little more update from an ICB perspective. Thank you.
Thank you, Claire, and good afternoon, Chair and Councillor colleagues. If I may, I would just like to obviously touch on two elements that we have addressed in the paper. One of those is in relation to our operational planning, and the other will be covering a little bit off about the Oliver McGowan mandatory training. So you will see in the pack that we have provided some intelligence in relation to our performance against our plans that we put forward in last year. We continue to monitor our performance through appropriate governance arrangements and through our system workforce committee, which we hold monthly, and whereby we obviously challenge and confirm with each other, and with a view of sharing any best practice so that we can support where we are seeing challenges across the system. For this year, this meeting is extremely timely, as we have started planning much earlier with our NHSE colleagues, and we have been requested to provide two submissions. One submission which was due in today at 12 noon, and I am pleased to report that all of our providers and ICB were able to manage that deadline, was required to put forward a 2-year workforce plan that would be triangulated alongside their finance and their activity plans, with the view that we will then be required to complete a further 3-year plan by early February. This will be complemented by a commissioner's 5-year commissioning intentions plan, and the providers will be able to also provide some further narrative in relation to their workforce numbers within their integrated 5-year plan. As we have put in the pack, our focus very much continues on increasing our productivity, right-sizing and maximising our capacity and our capability across the workforce, and ensuring that we can ultimately demonstrate that added value and have value-based outcomes and improve, obviously, the patient experience. All, of course, with a view of us working within our financial envelope. To help this, so far, we have our providers, our primary care, etc., have obviously reviewed their establishment reviews and have aligned that to their activity and demand and their clinical strategies. We have a continued ask in terms of reducing our reliance on bank, and providers with their current plans will be needing to reduce in between 7.5% and 10%, with an agency needing to be reduced by 30%. All in all, we will need to obviously have a zero reliance on bank and agency by 2030, and obviously it is anticipated that our plans will obviously outline how we do that. My colleague Claire has just highlighted the importance of also trying to reduce sickness absence, which is also a factor that enables us to rely on temporary workforce. And with that in mind, our ambition is to look at reducing our sickness levels to 4.1% over the next 10 years, in line with the 10-year plan. If I may then, I will now like to obviously move on to Oliver McGowan. Again, I will draw your attention to some of the updates that we have provided within our pack. As you know, Oliver McGowan was and is the government's recommended training, which to meet our statutory requirements under the Health and Care Act. Lincolnshire has approached the implementation of Oliver McGowan as a true health and care system, with all stakeholders involved. Led by myself within the People Hub, we have worked with our stakeholders to ensure that we are adhering to the code of practice and this was approved by Parliament in September 2025. To date, as I've outlined in the paper, our focus has been on completing Part 1, which is an online e-learning programme lasting about 90 minutes, and we have proven very successful in our performance, and we have indicated within the pack obviously our compliance to date. We have then also worked in partnership with other systems to deliver Part 2, which is further done via Teams and is also led by people with lived experience. For those individuals that have participated, we've had some tremendously good feedback in terms of the quality and the increase in knowledge that participants have gained in undertaking that training. As we move towards our furthermore into our cluster arrangements, we are keen to continue to collaborate across Nottingham and Derby, and also to adopt some consistency and learn lessons from one another and adopt best practice. We are therefore now have a focus on completing an options appraisal, which will be drawn up to present to our providers for them to then obviously decide how they wish to proceed in ensuring that they can deliver a sustainable plan for performance against the Code of Practice. I am aware that commissioners will offer support with this and obviously ensure that it is written within their commissioning contract intentions moving forward. Thank you very much for listening. I will now pass you on to my colleague, Vicky Lightfoot.
Thank you. Good afternoon, everyone. I'm going to just go over some of the more strategic projects that we've worked with our workforce on in Lincolnshire. So from our develop aspect of our plan, the creation of the Health and Education Partnership this year, where we've brought together local colleges, the universities and our health and care providers together to strategically review the training requirements of those aspiring to go into health and social care careers, but also those in health and social care, to see how we can collaborate better, considering things like student placements, experiences, and then the skills and the development we need in our current workforce to meet the 10-year health plan going forward. So that is meeting regularly, and we have various subgroups from that partnership where we're developing relationships to better enhance those working relationships between everyone. We've also looked at creating learning pathways, so we have a clearer footprint across the whole of Lincolnshire in those developments of pathways across health and social care careers. We've also still utilising and working in our ethos of growing our own, and we are using our apprenticeship levy and looking where those skills and gaps are to ensure that we maintain those skills required to deliver the health and social care requirements that are needed. From a grow perspective, we have spent some time this year with Breaking Barriers initiative and focused on our coastal area and worked with our voluntary sector to map what we currently offer across that East Coast and Boston area to support people into careers in health and social care. And we were one of only 10 successful sites this year in getting the widening access funding. We've now created a programme called Next Steps Lincolnshire, which started in August, which is focusing on getting people either under 25 or over 55 into employment and careers within health and social care. We've also worked with the council this year and the careers service, and we have updated all our careers pages in the careers web page, and making sure that we reflect the diversity of roles that are available in health and social care, not just the sort of stereotypical nursing and healthcare roles, but some of more of our diverse roles in estates and those opportunities available to people. And from a retention point of view and retaining our staff, we've had a focus on our international recruits this year, and we were awarded some Stay and Thrive funding to support those staff who have come across on our previous international recruitment to integrate into the community and also support them with their career development so that they're not just here for a short time, but they decide to stay and remain in Lincolnshire. So we're doing some work around social activity and wider integration for those staff. And we've also, though not directly with our workforce, where we've seen that shift in the 10-year health plan in terms of economic health inactivity, we have been supporting the Get Lincolnshire Working programme and also the Connect to Work programmes, and how health can play a more fundamental role in that as well. I'd like to pass now on to Sarah Jane to see if she's got anything else she wants to add from a primary care perspective.
Thank you, Sarah Jane, and thank you to our presenters. Members of the committee, do you have any questions, please, of our presenters? Councillor Mackinson-Saunders.
You spoke about growing our own. In the summer, I was talking to somebody who'd spent 3 years training to become a registered nurse. He and a number of other people that had been on the course were finding it very, very difficult to find jobs because of your international recruitment. And they were extremely vexed about the whole issue. They were telling me that some of those nurses were already pregnant and weren't working in the system, etc., etc. It was a long list of grumbles, and quite frankly, you talk about growing your own. I don't think the examples that I could put in front of you actually showed your commitment to that.
Who'd like to come in on that one?
Yes, thank you, Chair, and thank you, Councillor. And I'd like to take the opportunity to respond to that, because we are very much about growing our own, and indeed had a high intake of newly qualified nurses this September. We haven't recruited internationally, certainly as an acute hospital or a community hospital, for a large part of this year from a nursing perspective. So we are working really closely, Councillor, with the local nursing schools to ensure that those coming out of nursing training are not disadvantaged or find themselves in a position where they do not have employment. That is absolutely not what we aspire to be. Our international colleagues are very valued and are absolutely a member of our wide workforce. However, we have those local commitments to grow our own. So I hope that offers you a little bit more assurance on that specific example, Councillor. Thank you.
I will check with the individuals. They were most disgruntled and didn't
Please
feel
do.
that they were being supported.
So please do, and please do come back to me if you need any more information on that, Councillor.
Thank you very much.
Thank you.
Thank you. Councillor Kendrick, please.
Thank you, Chairman. Just a couple of things. Staff survey response rates. I'd be interested to know how they've changed over recent years. I know LPFT used to have a fairly good response rate to staff, but generally there's a degree of cynicism, I think, in the NHS on the former NHS colleague here, I think, is noting that one, on the whole issue of staff surveys, because whether anything actually came out of it at the end of the day instead of improving the situation for staff. And the other thing is, I was reading, I think it was one of the background reports to this, and there was a statement which I shall read out, which says, not all GP practices provide valid data in terms of staffing. And I was a bit surprised to see that, because I would have thought that would be mandatory upon GP practices to provide valid data. So if I could have an answer to those questions, that'd be great. Thanks very much, Chairman.
Thank you.
Thank you. Thank you, Chair, and thank you, Councillor Kendrick. I think it's fair to say from a mental health perspective, Councillor, that they have had a really good engagement and uptake and sustained that. From a acute and community perspective, we've done a lot of work this year in terms of there is a cynicism around the staff survey the 20 years I've worked in the NHS. Is it really anonymous, and what happens with the information? So we've done lots of work in the community and in the acute part of the hospitals in terms of encouraging staff to have a voice. And I'm pleased to say that early indications show a 12% increase for both community and acute, whereby last year we was recognised as one of the most significantly increased acute hospitals across the UK for engagement scores improving. So we're still not where we want to be, but it is going in the right direction. So I hope that offers you some further information, Councillor Kendrick. In relation to the GP practice validator question, could I defer to Sarah Jane to perhaps pick that up, please? Thank you, Chair.
I think our GP practices are strongly encouraged to submit accurate data through the WRS so that we have a full picture of information. But there are some complexities in terms of the details that often get submitted in terms of information, and there are some delays for some practices. It's something that we work very hard with them on, and it does have implications. So if Reid was here, he and I frequently have conversations about the importance of workforce planning submissions for a system point of view. Not that it is acceptable in terms of an answer, but I think often from a practice point of view, they do their workforce planning on a practice basis. So for running their business, they have all the information and they don't always understand the relevance of submitting the information into the national database. And so my colleague Wendy Cundy and Anna do a lot of work with those individual practices to encourage them and to make sure that the information is accurate. And also we follow it up from a primary care team where we become aware of gaps in the data.
Thank you for that, but I was just surprised that it wasn't mandatory, because something as important, having accurate data, seemed an important thing to me in terms of planning, and I'm really surprised that it's not a hard and fast requirement upon GP practice to provide that data. To encourage them is not going to get the data necessarily, because they'll say, well, fair enough, we're not obliged to do it, so they won't bother.
It is a requirement, and that's why we follow it up in terms of them submitting. I think the challenge that we have is often with the accuracy of the information as opposed to people not submitting it or the timeliness of their submission.
That would explain the term in the document I read which said valid data then.
Yes.
Thank you.
Thank you for that. Councillor Lee, please.
Thanks, Chair. You noted my cynicism about the staff survey. Many years ago, I remember I filled that survey in religiously as a nurse every year. And many years ago, in the end, I put, I'm sick of filling these in because you don't take any notice of what we say. Because I used to be really worried about moving across the hospital to another area. And no one ever took any notice and stopped doing it, but they didn't have the staff. And someone actually came back to me and said, oh, please fill it in. So I think maybe it wasn't anonymous at that stage, but they still didn't stop moving us. So I'm not sure how much good it did. The second thing, training. I'm really pleased to see all the stuff about training, because when I became a nurse, I remember having to go back to college to get A-levels at the same time as I was working in Tesco in the daytime. So the fact that it's more accessible is really good, because I ended up nursing for 20 odd years. Agency staff. I think they get a really bad press. I think it's terrible that they have to be paid so much money and it costs so much, but at the end of the day, for a long time, they kept the hospital functioning. And if we didn't pay them, it wouldn't have kept running. Finally, the bit about retention and international staff, I was a bit disappointed by that comment, and I don't make this personal, but I worked in cardiology, and the international nurses, I used to say to them, I take my hat off to you. Not only have you come to a different country, you've learnt a new language, you've got a new environment, and on top of that, most of them had kids. They were facing all of those challenges, but they still came and they still did the same day's work that I did. So I had absolutely nothing but admiration for them. And I think in the current political and social climate around issues that we're all aware of. It was a bit of a disappointing comment for me, and I absolutely took my hat off to the international staff. And again, Lincoln County Hospital for a very long time wouldn't have functioned without them. So I'm sorry, I disagree on that one. Thank you.
Anyone like to come back on any of those points from our presenters?
Yes, Chair, if I may, please. Thank you, and thank you, Councillor Lee. I think the comments you make around international staff, we have to remember absolutely that these staff have come to a different country, left their families usually in their home countries, and we work really hard to integrate our staff and not to differentiate, because they're members of staff that look after our residents of Lincolnshire. And you're absolutely right, we wouldn't have been able to function as a hospital without the dedication of some of our staff who are not local residents. I think the balance now is, how we continue to make all careers accessible through different learning pathways. I myself did an MBA as an apprentice through the NHS, which I would never have had the opportunity to do. So it's how we continue to enable our staff to evolve and grow their careers with the support of the apprenticeship levy, with the support of the training, with the support of not knowing traditional ways into education aren't always available to some of our harder to reach areas. So it's really important that we continue to work with the places like our Talent Academy, where we're out in the schools, we're doing things differently. Because I do feel that some of our areas of deprivation, if you don't necessarily have influence or networks to know how to reach those pathways, how do you become aware of that as a school leaver or as somebody wanting to change a career? So I just wanted to thank you, Councillor Lee, for your kind comments, and we continue to have that as an absolute priority in terms of those pathways to development. Thank you.
Thank you very much. And finally, Councillor Reeve.
Thank you. I was quite surprised to hear that we're still so reliant on foreign staff. It's been going on for many years. A number of years ago, Lincolnshire Health Service sent staff over to Spain to recruit a number of medical staff. And within a few years, they'd all gone home. I find it distressing as well that it would appear that people who are trained locally, according to what I've just heard, aren't given the opportunities, and that people coming in from abroad are prioritised. I also worry, though, that people coming in from abroad are cherry-picked from environments where they may be the best qualified people in those environments, and that we're taking away people who we could train ourselves from places where they're needed in their home country. And I just wonder, do we have a long-term strategy to stop bringing in people from countries where they perhaps need them more there themselves? Thank you.
Thank you for that question. Would anyone like to come back on that, please?
Yes, please, Chair. And thank you, Councillor Reeve. Just to reiterate, our international recruitment programmes have remained quite static in the last year, because we've stabilised the workforce quite significantly with both locally trained, newly qualified and international support. So it's not a case of one or the other, Councillor Reeve. It's very much a case of retaining our workforce, stabilising our workforce, and from a acute hospital perspective, we are in a stable position from our nursing vacancies. So when I first joined the Lincolnshire system, the nurse vacancy gap was quite significant in the Lincolnshire acute side of the provider land. We're now in a position where we've got the lowest vacancy position that we've had for a number of years, and that workforce has really stabilised, meaning we've seen less turnover, less leavers, and much more reliability in terms of filling those rotas and those shifts for the benefit of our patients. So just to reiterate, Councillor Reeve, we are not recruiting international colleagues at the expense of local roles and jobs. It's very much an amalgamation of both. And moving forward, we'll continue to ensure that all our staff get the support that they require and deserve in line with the workforce plans and the agendas moving forward that have been asked of us from a national perspective. So hopefully that helps clarify. Thank you, Councillor Reeve.
Thank you. Councillor Reeve, you want to come back? Thank you.
Yeah, also, it was just, I did have concerns as well that the international staff we're taking away from countries that particularly need them there themselves. They often come from third world countries, and perhaps they need them there quite as much as we do, but we're cherry picking the best of their staff, and is that the right thing to do?
Yeah, thank you. Sorry, I forgot that part of your question, Councillor. There are national guidelines in terms of which countries you can recruit from an NHS perspective that are applied across the board in terms of ethical recruitment, which takes those factors into account, Councillor Reeve. So there are a number of countries where international recruitment cannot be done, so therefore visas are not issued or supported for those ethical reasons. And that's a government-led requirement that we have to comply with, Councillor Reeve. Thank you.
Thank you.
Thank you. Thank you to our presenters. Any other questions from members of the committee? No, I see no hands raised. So it then leaves me to thank our presenters for their report and for answering our questions this afternoon, and to move to a proposal. And my proposal is as follows: that the following be noted. A, the achievements and successes you've made over the last 18 months. B, the current context and operating environment. C, the potential implications for people and workforce in the context of the reforms that have been announced. And secondly, that the continued partnership working across healthcare and education partners in support of the health and care workforce of Lincolnshire be endorsed. Do I have a seconder, please? Councillor Reeve, thank you very much. All those in favour, please show. That is unanimous. Thank you very, very much. We obviously covered the work programme earlier, so it just leaves me to wish members and officers a very happy Christmas. And that concludes the business of the Health Scrutiny Committee for this year, this calendar year. Thank you very much for attending, and the meeting is now concluded. Thank you.
Thank you.